state. So those are not in the cost statement. And so that, the $962,000 here on the cost summary. Those settlements were direct settlements. So those that you run through the Colorado MOU that all of these jurisdictions have signed on to, those were settlements that were made directly with those providers. And so while they ran, they have to be spent and appropriated the same way they did through the state. So they're not in our cost database. And then there's a small amount from when Purple Creek and Palmer Lake decided to redirect their funds to this council when they previously had decided to do it themselves. So, does anyone have any questions on that, Angels?
Thank you.
Okay, so next we're going to move into the applicant presentation Q&A. First presenter is Silver Key Senior Services, Inc.
Well, I appreciate the opportunity to present a little bit about Silver Key and why we would be one of the applicants within this funding. One of the challenges that we have in this community is that oftentimes older adults are the most invisible people in the community. And the reason why that is because sometimes we forget that people that are older adults have needs like the rest of the general community. And in doing so, there's some things that unfortunately happens with older adults. First is, in the state of Colorado, El Paso County directly has the highest suicide rate compared to statewide for suicidality in older adults. That's in our community now. The other piece that I will share with you is that oftentimes suicidality links back to where people are stockpiling medications in the older adult category over the age of 65. In that stockpiling of medications, oftentimes people will potentially use those medications not in the best prescribed way. And what happens is the death will be attributed to accident, when in fact, it may have been intentional in some cases. And that's outside of what the stats show about people who are dying by suicide. The other piece I'll share with you is alcoholism. There is no report in Colorado for the number of people that are over the age of 65 that suffer from alcoholism or addicted to opioids and other narcotics like that. Nationally, 5% of the population over the age of 65 suffers from alcohol abuse. 1 million people over the age of 65 suffer from opioid addiction as well. Now, one of the things that we don't have in this community is identification of numbers to be able for me to demonstrate to you, well, how would you actually be able to tell a quantitative impact? So what I'm going to bring and propose to you is that the programs that Silver Key has, whether it's our Meals on Wheels, or whether it's our transportation, or whether it's our behavioral health team, each one of the ways that we connect with individuals, what we're able to do is identify people with signs and symptoms who need help. Now, that may not be intuitive to you, but I will tell you, if you have a family member that's living alone in the community, one of the best places and spaces for us to be able to provide support is for Silver Key to be able to connect with that individual. Now, what you may not know is that some of the people in that older age group sometimes have cognitive loss, memory loss, and they may have been healthy well as they were getting prescribed medications. If any of you have older adults in your family, oftentimes you will see that there'll be cupboards of medications. What we're proposing today is that by helping us support a way to be able to broaden the connection with our staff who are involved in so many different ways, as I've said, Meals on Wheels, we're the Pikes Peak designee, our transportation, we're the artery for people to get to healthcare. The other piece that we do all the time is support people for food access through our pantry. But if our team really understood to recognize signs and symptoms of addiction, abuse, and other issues that could be emerging for somebody, we can proactively respond. But right now, many of the people that are part of our system are great people who just want to do good by supporting elders in our community. We're flipping the script on that because one of the things that we understand is that if we can train up our teams to recognize signs and symptoms proactively, we can actually do something about that and help that journey of aging be different than what that path would be without intervention. What I'm proposing and you support is that dollars were able to come in to help us build and continue to build our core team to be able to be trained up, to be able to have the tools and the knowledge to be able to be those intervention teams, identification teams. We will be able to activate care differently for individuals. Now, that may not be intuitive about how does that make sense in this group, but I'll tell you why it makes sense. Because one of the things that we know is the highest rate of cost is older adults. Because the level of care that they sometimes need, that healthcare system is sometimes overused by people who truly do not need that level of care. What I mean by that, as we went into partnership with Colorado Springs Fire Department, with NAMI Colorado Springs and the Innovation in Aging, they were operating entity, those groups came together, and what we were able to identify is something that's very unique in the older adult population that isn't really measured anywhere else. We have a way to pull an instrument that's called the Hope Scale, the International Hope Scale. This is a nationally recognized, actually internationally recognized, it has the psychotropic medication, psychotropic. It's statistically valid and reliable. So with that statistically valid and reliable instrument has the ability to actually demonstrate where one's hope is. So ironically, there was much more research internationally about what does hope mean in older adults. The result was if you have a lower degree of hope, you have a higher utilization of 911 and emergency room placements. That is how we were able to demonstrate. If you go to the next slide, demonstrate this statement here. We had an independent review to be able to demonstrate by us getting involved proactively and preventatively with our wraparound care, identifying signs and symptoms. And we did this without necessarily having the core training about recognizing issues around opioid abuse and use. Imagine if we added just that additional piece for our teammates to be able to do this. We could save this community even more dollars, because what we were able to do is using the International Hope Scale, we demonstrate by getting involved with Silver Key, we increase hope and we reduce that expense. I can only imagine that if you support our organization and what we've applied for, which was the 47,616, the 30,800 to training staff level, the additional expenses alongside that. For this level of investment, what we will be doing is we will begin to outfit our teams to move our organization to achieve a level of designation as an evidence-based practice for the entire Silver Key organization. Because what that means is that we're investing in people that are not only just do good people, but they will know how to do good and do even better, because we're going to outfit them with the training to be able to be effective and recognize the signs and symptoms, being able to link them to care. And through that, we will be able to demonstrate that we will be able to reduce the burden to the taxpayers by reducing the cost to Medicaid and Medicare, because 911 will be less used. We've already demonstrated that. Emergency room use will go down. We've already demonstrated that. Give us the power to be able to amplify that. And I can only guarantee you that we will have a way to bring more opportunity for this community so resources can be more effectively used in other venues. And by the way, older adults should not be the silent population of our community. We stand on shoulders of giants, and I invite you to help me make sure that those giants stay strong as long as possible, because they don't deserve to be in higher level of care when we had the solution. Isolation and loneliness is the cancer, and Silver Key is the cure.
Thank you. We're going to open it up for questions and answers. I see I have another copy. Looks like you're sharing a copy right over to you. And as a reminder, the presenters, we have 8 presenters today, so we're going to get a 3-minute kind of overview. We have your slides. The council has read your presentation. So with that, we'll open it up for Q&A.
So thanks, Jason. So a few things. I appreciate the fact that you're putting some money into the budget to kind of match, so to speak. So that's, I do appreciate that a lot. I think this is needed. Can you help me a little bit to understand better? So you're going to train, for instance, your volunteers that go in, meet with them, or maybe deliver some things to them. And then you're wanting to train them so that they pick up on the signs and symptoms. And then what happens next exactly? How is that going to look as that transitions back?
Yeah, so first we're going to start with our staff, because our staff will be the ones that will be supporting the volunteers. And my next iteration will be the volunteers as well.
And then they're going to train the volunteers.
Exactly. So it'll be a trainer kind of work. The intent is that what we will do is we'll be able to outfit our staff and our volunteers to be able to recognize the symptoms and then be able to link them into the Strength of Silver Key's behavioral health team or the partners that we have. We have many different partners around the room in the community here that we link to and provide those services. And in many cases, they just would not have been linked over because it's not the population that generally gets linked over there.
Great, thank you. Additional questions? Councilman Bennett.
Jason,
Yeah.
how many seniors are you gonna serve with this program?
This one, 300. We serve 12,000 seniors overall, but and we will continue to build the support through our Hope Scale for all 12,000 that we serve. But this will be very targeted. One of the things that happens frequently is individuals don't know their pharmacist, they don't know their pharmacy, and they don't know how to actually have conversations with their pharmacist. So the people that we train will move alongside with individuals to meet with their pharmacist so that they can actually understand what medications should I keep, should I not, what do I need to destroy? And oftentimes those will be the opioids because of pain management issues.
Thank you.
Yeah.
Any additional questions?
Can I make a comment? on that?
We have a comment from the audience.
Just a comment. I have helped to facilitate, I think in total 6 drug take back days at a local community coalition. I don't actually have a real percentage, but just from what I've seen, I would say 60% of the people that are bringing their meds are senior citizens. And although they're not exactly supposed to share, it's supposed to be like anonymous. A lot of them do share what they're taking and like what's in the bag. A lot of them are opioids, so I really appreciate what you're doing to kind of meet them where they're at. I know sometimes we make the assumption that if a senior citizen does overdose, it's an accident, which sometimes it is, you know, maybe we reach for the same, we forgot that we already took our medication, but there are some that are not in that category, so I really appreciate what you're doing, thanks.
Thank you.
Any other questions from the council? Okay, hearing none, thank you for your time.
Psychotropic meds. Downloaded reliable.
I need to stay in the room, please. There might be further questions for the voting session. UC Health, next chapter. So as a reminder, the council has your presentation. They have read your data. Oh, sorry. They have read your application, so we're looking for 3 minutes somewhere over the record.
Yes, sir.
Yes, ma'am. Thank you.
Thank you. Good afternoon, everybody. Appreciate being able to come back. See a lot of friendly faces around the table. My name is Damian McCabe with UC Health. And as part of my introduction earlier, I shared I'm Director of Behavioral Health for really everything South Castle Rock in terms of behavioral health and addiction services. Joining me today is members of our team, Dr. Leah Jackson on the end, Roger Johnson, Miguel, and Jose. And any one of them will respond to a question you have. So if you feel like getting into the weeds, the weed team's here to go through this with us. So what you have in front of you is basically a note taker because this is a big project. There's a lot of detail in it, a lot of complexity in it. But the high level overview today really is, we ran this project for 3 years to get after veteran suicide in our region. And you don't get after suicide unless you get after the collateral circumstances around suicide. Obviously, mental health is one of those. Things like employment, relationship problems, problems with the criminal justice system, problems fitting in, isolation. Of that list I just gave you, all of those same things factor in a person's choice to use or abuse either prescribed medications, opiates, sedatives, benzodiazepines, or illicit medications, fentanyl, heroin, right? And all the others that go with. So our perspective or our view on how we intervene did not take a singular one person, one substance approach, but a holistic approach around a person's life who is in crisis or in distress, or just barely making it and moving to a place where they can thrive, where they're not considering taking their own life, where they're not dependent on opiates or other drugs to get it through. The folks that we serve are veterans and their family members. Why such a select group of our community? Well, if I did a survey in this room right now, I'm pretty sure I can tell you how many hands will go up. But let me just give you the numbers. There's about 110 active duty and 110,000 active duty and veteran individuals in our community, in this ROAC region. If you take a multiplier of 1.5 for their spouses and family members, do the math. We're pushing 300,000 up through Teller County and Southern Park County. Right? That's about a third of our regional population. So when we think about it as a select piece of our community, it's almost a third or more of our community. We ran this program. We had an external evaluator look at everything we possibly could do. Our money, our programming, our quality outcomes, our clinical outcomes, our access to care. completely objective outside of UC Health. And they came back with a final report. I'm presenting you today in summary, some of that data. We are in one statement of work area talking today, but this program crosses into many. Okay, so they're up there. The really important, and I think you'll all see it on your slide, the really important outcomes for us is we'll be able to reach a population of people who previously are underserved because they have self-select not to get care for lots of different reasons. Or when they do get care, people don't understand how to work with them in a unique way that veterans present. And I'm talking about veterans from 21 years old to 91 years old. Jason and I built a partnership with our organizations that allowed us to reach veterans from World War II who the only medication they were choosing to take was an opiate, not to treat pain, but to get away from the war. And we would have their families call us and say, they're gonna die if we don't do so. And we did so. We had a lot of them. We also have our young veterans who got injured. Cervical spine injuries, lumbar injuries, the chronic injuries that stay for life. And what is our medical primary intervention these days? Pain management. Pain management often leads to dependence. And once they're dependent, then that propagates across other drugs. So let me give you some results. The first thing I want to point out is this very top statistic. Our goal was to get after suicide. Of the 1,250 people, which was about a 72% in excess of our goal of 700, we overserved our goal. No one took their life. No one. We're really proud of that stat. In that group of folks, I'm not going to read them for you, but you can see the data around what people thought about the program, how beneficial it was to them, and the objective outcomes that we could measure. We measured everything. If you get something north of 70% in any healthcare intervention, you have something that works. Do you always know exactly why it works? No, that's what research is for. But you know that it's making an impact, and you know that it's fiscally responsible to do things that reduce the number of people coming into the ED, reduce the amount of people that the PD has to deal with. I have co-responders out with chiefs folks and with El Paso County folks every day. And their work in our community prevents costs in our EDs. And EDs, you all know this, preaching to the choir. EDs is not where you get treatment for opiates. ED docs will basically say, you're not getting anything. Next. And then my team has to figure out what next is. Well, this is what next is. We're in Judge Shakes' court. Every time Judge Shakes says to a veteran, you need to get treatment or detention, that cost typically either goes to probation service or back to the county. Every veteran we picked up in Judge Shakes' court that we took on who had a behavioral health and an opiate-related circumstance that would result in detention is sober today and never violated their program of care that Judge Shakes put out. But that cost a lot of money. But it was money that came out of this program and not out of, well, not necessarily your budget, but the probation services budget.
So with that, I'll open it up for questions.
Great.
So you're part of UC Health or partnered with UC Health. Do you plan to open a chapter up in Teller County at that site?
So appreciate the question. Next chapter is hard to define to people. Next chapter is not a thing or a place. It is a collaborative in our community. It rides on the backbone of the UC Health infrastructure. So we use the medical records, we use booking, billing, appointment, all of that. So we're already part of the Teller County Veterans Task Force in the form of one of my clinicians who operates out of Woodland Park. And many of our current participants are from Teller County. So the short answer to your question is yes. Well, will we open a chapter? No, we'll partner with people in Teller County, serve veterans and their families in Teller County with Teller County expertise. And we will bring additional training to those folks who work with veterans.
Any additional questions?
So thanks for the presentation. A few things as I read through this, I wanted to ask more about. Can you explain mindset process behind three different things related to the fiscal ask, which is quite extensive? Direct clinical care, why the amount of dollars for direct clinical care. Same with subawards, and then finally, why the mindset around the zero out-of-pocket cost. Even Medicaid makes you pay a little, so.
Yeah, no, it's a great question, Steve, appreciate it. So let's start with the large number in direct care. Jose, what do we spend in 3 years in treatment of dual diagnosis and comorbidities, out of our budget?
For the residential treatment loss,
Or the soup to nuts?
$1.4 million for the residential treatment, but soup to nuts right around 4.2 million.
We're basing our ask off what we've already done. And so those of you who work in treatment know that just the first part of entry into treatment, if you need detox, phenomenally expensive. If you need to go to residential, it runs somewhere between 1,100 and 1,500 bucks a day. If you have to be on Sublocade or Suboxone or one of the other medications for a short period of time, it's another massive expense. In general, when we took a veteran and put him, and because not everybody needs it, it's a very small portion, but about $80,000 per veteran to get them off the street, who are likely to experience significant medical circumstances from withdrawal, and get them all the way through a year's worth of outpatient restorative care into employment or education and training, usually runs between $80,000 and $100,000. That's not a lot of money if you had to do that for a lot of people. Well, that is not our primary intervention. Our primary intervention is stay at home, stay at work, stay with your family. You're in outpatient care, you're in group care, you're in pro-social activities. So that's where it feeds into the subawards. Those other organizations that we work with in collaborative, we have to cover their costs. So for instance, as Jason spoke earlier, we had a program with Jason's team where we underwrote, paid for essentially, his crew to go to veterans' homes, veterans and their family members' homes, to provide us that sensor, that sentinel in the home who could pick up on indicators of distress. So they would be in the home, maybe delivering Meals on Wheels, but they're trained to detect crises, they're trained to detect depression or anxiety, or misuse of drugs and alcohol. So if they went into a home with a meal, and there's a bunch of foils and some lighters around, they're giving us that input back. Because when that person asks us for care, they aren't all candid about what their need is. But we can then proceed knowing that we have maybe a dual diagnosis circumstance or somebody misuse of drugs and prescription medications, specifically opioids, especially around fentanyl. And remind me your last question. So,
The zero out of pocket.
so the zero out of pocket. Again, this is preaching to the choir in this room. The number one barrier to getting care in substance use and mental health in the United States is cost. It's cost. There's no other way to say that. So if for 30 bucks, us underwriting a copay, I can get you off the street, I can get you into care, I can save your life, then we're gonna put that out there. Because sometimes just getting the copay is the barrier to that first step in. That's really the mindset behind it. Medicaid does make you pay something, and it's nominal, but I really don't get into the politics of how and why we get people to buy in. With this particular community, the buy-in is around the cultural competency. It's the peer clinician. Every one of those clinicians back there is a veteran. Every one of them served overseas. When we say we walked in your shoes, we walked in your shoes. We got the same mud in our boots you had when growing up. So our buy-in is around the cultural competency, the seminal barrier in drug addiction or substance abuse treatment and comorbid treatment is that barrier around opioids. And if you have no money at all, well, you're not coming. It's just, it's got to be underwritten somehow. Now, I will tell you that in our financials, I can show you down to the individual person how much those copays actually cost us over the course of any particular person's care. In some cases, it's 90 bucks because they came for 3 sessions and they're good to go. I wouldn't recommend that as a treatment plan. I am for anybody. In other cases, they had 30 or 40 sessions. They were with us for a year. And so that copay does add up.
Is there another question, please?
So the program, the funding you're looking for right now is to establish for the next 3 years. How will you go past those 3 years?
So this actually, this ask is only to allow us to dedicate 50% of our program resources against substance use disorders, specifically comorbidities around opioid use disorder and mental health. In particular, our population, obviously, it's depression, anxiety, and PTSD. That's where we see most people coping. That's where we see them getting off the rails in terms of coping with illicit substances once they've exhausted their prescribed substances. So it's really only to give us that 50% cutout of what we do already, so we can focus in this particular substance use and substance use comorbid area. We have multiple arms of funding, so between funding through what are called the BASOs, which are the behavioral health administrative service organizations, those have just come into being this year. Previous to that was BHA. We are also partially funded through UC Health Barber by way of underwriting some of our positions. My position, a portion of our clinicians' positions, the lease on our property or some part of the lease on our clinic. We also were key advocates in the passage of Proposition KK dollars being allocated to expand mental health services for veterans. So we were advocates, and regardless of your politics, gun ammo and taxes, that money's coming. That $5 million is coming annually out of sales taxes, and we were key advocates for pushing through that. So that will be annually available pool of money that organizations like ours will be able to request support. The original program, the budget on an annualized basis is around 2.8 million for here and the Pueblo area. So we expect that we're going to continue to ask and receive funding through that program. This report that I'm presenting to you is commissioned by the BHA to ensure that not only was there accountability for the dollars, but to make a recommendation to sustain the program into the future, which is what they recommended to sustain those.
An additional question, Michelle.
So I work with a number of military organizations that are dealing with this. You know that. And one of the things is that we have been in wartime quite a while. And are you guys seeing numbers decrease? I mean, at some point you're kind of like catching everybody. Not to say everyone's fixed or taken care of by any means, or not to say that people have to go through this program 5, 6, 7, 8 times, maybe the 9th that catches, right? I mean, that's how these things work. I understand that. But what's your oversight? What's your thought or look at? Like, again, we're not in a war at the moment. Not to say that there aren't components of things that we do, and or certainly secret stuff, right? But could you kind of comment on that?
Yeah, absolutely. And I'm glad you brought that up, Councilman Lineweber. So 2 points, and if I may just gently push back about we're not in a war. We have soldiers, sailors, Marines dying today, right? So we are still in Iraq. We are still in parts of Syria. We are still in many places in conflict around the world. So today, a service member is still subject to deployment to a combat zone and still subject to the traumas that come with that and to the ultimate sacrifice. So that's just a general pushback. I know in general what you mean.
I mean, to a degree, we're not.
Yeah.
I mean, it's
Not
less
in the
of a-
volumes.
Yeah.
When we presented in January, I had with me Sergeant Heath Miller, United States Marine Corps, and I shared with you his story that he gave me permission to share of his all-American upbringing, his journey into the military, his journey to the noble cause of being a Marine, going to Iraq, then Afghanistan, and his less than noble journey to losing his friends, being injured, coming out, getting treatment, being habituated to opioid painkillers, to then moving into crime, to fentanyl, to trafficking, to being arrested, to being a client of the district attorney's office, and being and being a resident of the sheriff's fine establishment over Passage Street. It was 15 years after he came home that he found Next Chapter. He is sober now, and he directs and lives just out of town, but he runs sober homes for everyone in general, but he specifically focuses on veterans. 15 years, 5 goes at getting sober. He lost his wife to fentanyl, didn't divorce, died. He lost his kids to DHS, got him back. He lost multiple jobs, he spent time in jail. I mean, the litany, right? So even though we have not been in full conflict in the last, let's say, 5 years or so, we can wind down. I came back from Afghanistan in 17, and I think we really wound down major operations about 2 years later. And then of course I was going to about patrol.
Can I add something to that real quick?
Sure.
So the other thing to think about, even though we don't have, designated war time going on, we still have people forward deployed, but we have people in Veterans Trauma Corps who have served in Vietnam, who are, they eventually get, picked up on something and then they realize they've got some issue. So just the fact that we're not actively in a war doesn't necessarily mean that there aren't service members out there that need services.
Since Michael added something, if you don't mind me adding something.
No, I'm just gonna say thanks to you for stealing my thunder.
That too, because I think another thing to think about is we have service members. My husband still serves in the reserves, but he was deployed. And some service members are coming back with long-term impacts that they don't feel for a long time. But as a result of their service, whether it's being exposed to burn pits and we're doing all this, like there's all kinds of disruptions that don't come until later at life that can also trigger these things that don't happen initially, that I think, they're still gonna continue coming down the road.
Well, I just know of a lot of military organizations that are not able to get the same amount of clients as they used to, after Afghanistan and some of those other wars.
Yeah,
So,
actually, it's a really good point. So let me do a couple things. One, the Vietnam piece is huge.
mhm.
Here's what I would say of what we learned in the 80s. Remember Vietnam through 75? All our veterans were cool until the mid-80s. Then the mid-80s, we're like, hey, what's this PTSD thing about? Why? Because our veterans were falling apart, and in our society, we didn't know what to do. So we locked them all up. And our hospitals were full of veterans, and the VA was bursting at the seams when the VA had big hospitals. And so in the mid-80s, all of a sudden you realize, what the hell's going on? And war was over in 75. It's 10 years later. Why? There's a bow wave effect. And when people come home and reintegrate into family, it might take a few years before they realize, I had 4 jobs in 4 years. What's up? I'm always mad with my kids. I've had 3 divorces in 4 years. When they start stitching it together, maybe I'm useless. Maybe I can't hold a relationship. Maybe I can't hold a job. I drink pretty hard, but hey, everybody does, right? Maybe I get introduced to a substance that's not alcohol. Because alcohol is still the #1 gateway to other substances. Has been forever. I don't see that changing. But that bow wave effect, we are just now beginning to see it. I hate to be the doomsayer. We haven't seen the peak of the conflict of the last 25 years yet. It's coming. To DA Allen's point, one of the reasons we see a lot of folks that are Gulf War, Vietnam, Panama, even Korea in court these days is because of residual or circumstances that are physiological versus psychological. By that I mean the aging process is coming in. So back to my friend with Silver Key, when we think about traumatic brain injury, young people can cover it up. I'm covering it up right now. Many of you won't detect my speech impediment, but I have one. I'm also hearing impaired, but I have clues and I have friends in the room to signal me, right? But when I'm older, I will be less able to do that. I'll be less able to regulate my emotions. I may become more impulsive. I may be, if you will allow me to use the expression, the crazy old dude on the sidewalk. We don't have to have that happen if we can intervene now.
We call him Old Yeller. That's his name.
I want to be
He's right out there.
Wheeler,
It's Old Yeller.
telling stories about it.
That's his name.
But I do want to point to a couple of areas, Councilman Line, where if we intervene now, we make an impact and we don't have to be there. But I would tell you, we have a co-responder down at Pueblo right now assigned to the fire department, and their whole purpose is to go after people who call 911 over and over and over and consume all kinds of resources, just rolling trucks to something like, I can't find my keys. That's not because they're bad people. That's not because they have memory loss. It's because the normal course of aging is kicking in and we don't have systems for it. We have many, many veterans in our community and many are very successful, and I've brought a bunch of them with me today. So I don't want it to paint that veterans are dangerous and that they're the scourge of our community or anything like that. If we don't get this right, those veterans end up in adverse encounters with law enforcement, with PD or with fire department, with EMS, and we get them in an ED. It kills us when we get them in ED. Because they don't need to be. We should be doing something different. This is different.
Do you need to get any reimbursement from VA or TRICARE?
So, double barrel question. First answer, no. Emphasis, hell no. The VA will not fund any services outside of prescribed VA treatment plans. Doesn't matter who you are, unless it's a prescribed VA treatment plan and you're in panel to the VA to receive funds, you will not get reimbursed. So one of the key outcomes of this is that a veteran walks into the next chapter, we see them the same day if we can, or 24 hours, we reach them after they make contact. We will get them in to see an evaluator in 72. And they'll start treatment the next week. Does anybody know how long it takes to get into the VA? Next month, if you're lucky, 2 to 3 months if it's small. So the key in terms of getting to the crisis point of getting them when they're ready to make change is to see them as soon as possible. And even if that first visit is, what do you need today, Steve? Like, I know you're using dope, but what do you need today?
Is that whole true for TRICARE benefits as well?
TRICARE is different. Now, again, this is sort of why UC Health leads, because we are a built out healthcare infrastructure. So if you've got TRICARE and you come see me, I can bill your TRICARE. And so the cost of your care doesn't have to come out of the available pool of funds because I can bill TRICARE. Not everybody can do that. Not everybody's in panel to TRICARE and TRICARE is right. But with our infrastructure, we do what we do. We are seeing TRICARE patients for diabetes, for hangnails, for glasses. I mean, we just leverage that infrastructure like that. So every insurance company, not just TRICARE.
Yeah.
So if you have insurance, we have some people with premium insurances that are paying, their copay is like $5. And they're getting everything covered. We have general officers and we have privates that didn't make it through basic training. So again, we have that ability because it's right on the UCL background.
I just have more of a comment. That number doesn't scare me at all because if you complain about the number, you're actually putting a number on somebody's life. The fact that you did not have one person through your program of was 1,700, not one commit suicide is complete. No program has come through here that can say that. Not one has said that. You're the first. And the recidivism is what costs us whenever they do go through the jail system many, many times. So I can't speak for the DA, but I can speak for our municipal court that we just got a presentation on last week. We have an individual that came in that has like 50 case files for one individual, like 50. They're having attorneys. We're using judges. We're using staff. The jail, that one person. Right there is the cost of every department, city, municipality, the general fund, the police department, the fire department, depending on if they're there homeless ticket or however, whatever the case is such a huge cost saving that you don't have the recidivism there either. So that is a tiny number compared to what we're spending in Muni Court, in the jail system, in the DA's office. That's tiny numbers, tiny compared to what we're spending. What is it, 780,000 now? It went from 500,000 for attorneys to 850.
So $250,000 increase in the municipal court just this year because we hired 3 new monitors.
I wish we could solve the answer, which everybody in the room probably knows when someone says, how do you know no one died? Like, what's the data point? What's the statistic that says, oh, that person's not dead? We don't count that, right? I'd love to be able to say, how do you know someone didn't get arrested? How do you know someone didn't go to jail? It's very difficult to prove something didn't happen, right? But what we do have is we have cost trends like you just identified. So I'd be happy to inflate that number to a level where you thought it was going to happen.
I'm just saying that in perspective to what we're dealing with
Yeah.
in a municipal, that's not a big number.
And your point is well taken back. I want to come back to what zero means. It's 1250 participants, by the way. What we call, is that me? So what we in healthcare and everybody else who's in the healthcare nonprofit world knows that there's a way to calculate something called cost avoidance, which is what we didn't spend had the trend continued as was. I would take Sergeant Heath Miller's case. 15 years of criminal justice involvement, 15 years of public defenders, 15 years of probation service, 15 years of various law enforcement and fire. He was down 3 times and resuscitated by rescue EMS in our city. I don't know what that number looks like, but I know it's not small. Until he finally got to a place where he could benefit of an opportunity to become restored, not recovered, but restored. He works, he pays taxes, he gives back. He's a peer in our program for other veterans. And I will tell you folks that the overall goal of this program, it's not about stopping people using drugs. It's about restoring lives. It's about getting people back to thriving. It's about saving lives. And every time I say people, translate that to family, because you all know in this room, when we're dealing with the opioid crisis, there's no one person that gets harmed. If it's in a family, it's the whole.
Any other questions?
Comment in the back.
Well, I'll encourage everyone to kind of reframe their thinking when it comes to behavioral health. And what I mean by that is, you know, with the question about war, anybody who has been in recovery, whether it be for mental health or substance use disorders, knows that each day is a war. Each day of living is a fight won. And so I encourage you to think about that, because nobody ever talks about the silent killers, which is self-hatred. Nobody ever talks about the silent killers of, I am not worthy. I don't deserve to be here. My family would be better off if I was dead. Those are the issues that are at hand that we must address as far as this is concerned, because nobody wants to have to give that message to a family or a child.
Are there other questions?
Can you just repeat what the number was of individuals that went through your program?
1,250 people enrolled under the pretty rigid intake requirements the state set for us. So you had to have some indication of what we call the antecedents or the indicators for suicide or wanting to take your own life or engage in self-harm. Obviously, pretty high up on that list is substance use. And specifically if you've been treated or had emergency room visits or EMS visits, Narcan, that kind of stuff. So it's 1,250 people who had clinical indicators for at risk. A lot of them come into our EDs. That 1,250 received not just clinical services, but restorative services through our partners at Mount Carmel, supportive peer services through our partners at UCCS, at Silver Key, Mount Carmel again, through court. In fact, a lot of our court services really were trauma care. They were acute, undiagnosed trauma responses that people were coping with maladaptively, and our partners at UCCS did a phenomenal job at structuring a way for us to get people in quickly. I mean rapidly. Nicole's in a room. To go from being in court on Thursday to being in front of a clinician on Monday is unheard of in the world of outpatient addiction or behavioral health care, right? Unless you're like in detox, like you're in a medical detox and you're gonna get in front of a clinician quickly because you're gonna die. But on the outpatient side, it's unheard of. And we were able to do that kind of thing. So that number, that 1,250 represents that group.
I just have one more, just one more, with just serving with veterans, do you think, because we serve at this council, I don't know how many veteran grants we've given since I've been here, but do you think veterans are more at risk with dealing with alcohol, substance abuse for risk than the regular population?
Yeah, I mean, I think, you know, if you just Google it right now, you'll get one of the various bots or AIs, or maybe just a Russian hacker, and they'll populate your phone with the data around the increased rate of addiction amongst military and veteran service members, and in their families too, right? That part's not as well understood from the research, but why, as to why. What I would say as a veteran, and knowing a lot of veterans that are struggling with addiction, that's how families are coping too, is that veteran is impacting that family system. But between long periods of isolation, stoicism that's bred into you in the military, you gotta have your shit squared, apologies, you gotta have your stuff squared away Because if your stuff's not squared away, your team's not squared away. And you don't want to be the person that lets the team down. So you internalize and suck up a lot of stuff. You keep it to yourself. We can only take so much as an individual. So where's the outlet? And I hate that, you know, a proud veteran. I know there are proud veterans in this room and an Navy veteran. But alcohol and drugs are the place where you can go and cope and still figure out how to stay in the military. When you get out and you've transitioned and that identity and that mission and that purpose has been removed from you by way of transition to a new identity as a civilian, alcohol and drugs are still available to you to cope. And so there's a priming effect in terms of where do you go to cope, because you're not going to go ask a therapist for help. You're not going to go ask a cop for help. Okay, you're likely not to come to the ED. Everybody's probably seen the old Monty Python. It's just a flesh wound. You're not coming in when you have a pain. You're coming in when you have a limb hanging off and going, I just need an equity. Okay, because otherwise you're dealing with through drug and alcohol, and whether that's a psychological injury, a physical injury, or a chronic disease setting in like sclerosis. Or you've got some bad junk. Our biggest problem in ED right now, I'll tell you, people come in and go, I was just smoking some marijuana. Cool, you're positive for fentanyl. I never used fentanyl at all. Where'd you get your marijuana? Laced with fentanyl. Wow. Okay. And so a lot of veterans out there at risk at higher utilization of marijuana are now exposed to fentanyl. Don't know where that marijuana. I wish it was different. I wish we could say there's clean marijuana in our dispensaries and everything else. It's not the case.
Are there any final questions? Hearing none, thank you very much for your time.
Thank you. Appreciate it. Appreciate the questions.
And before I let the next presenter is going to be Antelope Recovery. Right before they come up, I have a question for the chair. So our protocol in the past has been to hold public comments at the end. Would you like us to go back to that protocol?
Yeah.
Okay, so I'll adhere to that protocol. So please preserve public comments until the end. And we'll open it up right now.
Just to keep us on schedule.
Right, and we'll open it up for Antelope Company.
I don't know. I'd like to start out by saying thank you to everyone in this room, to all the organizations for all the great work you do, and to the council for your time and for allowing us the opportunity to speak here today. My name is Jacob Austin. I'm the Associate Director of Outreach and one of the peer mentors at Antelope Recovery. We are here today because we feel that it might be here that we're needed the most. We are a fully virtual provider, so we serve the youth all over Colorado, but we think we need to focus our efforts here. In the recent years, Teller County faced the highest youth suicide rates and the highest amounts of youth overdose ER visits, with El Paso County not far behind. And while we are breaking down the stigma of behavioral health, there are still some challenges we need to address. Female youth are twice as likely to be admitted to the ER for an overdose, yet youth male in the area are twice as likely to die from an overdose. And it's not just male that are an underserved demographic. It's the youth that are part of military families, come from rural communities, don't have access to technology, speak Spanish, or are economically disadvantaged. So we are here to do something about it. Through this grant, we aim to reduce the amount of youth fatalities related to SUD and ER visits. We want to increase the utilization of treatment and resources amongst the youth in rural communities. And then we also want to improve the quality and expand the access of behavioral health care for the youth of military families. And last but not least, we want to help develop a coordinated care network that streamlines access and cultivates comprehensive care for the youth of all of the Pikes Peak region. Next slide, please. So yeah, there's the outcomes that we intend to achieve with this grant. And you can see here, we've kind of allocated it into different camps here. We've successfully managed some big grants in the past. And so we feel comfortable with putting these funds to good use. The top being for the rural families, increasing access, awareness, and streamlining the referral process. And then underneath for increasing the quality of care for military families. Some of these things are not reimbursed by Medicaid, which is why this grant is so essential for us achieving this mission. Thank you again for having us here. I appreciate your time, consideration. I'd like to open up the floor for questions.
How many youth do you plan to reach?
Good question. So in the rural community, we want to reach 30. And then the military families, we plan to see, I believe the grant said it was 25. And over the past year, we've already served 16 youth in the region. Some of those have come from ERs, the 4th Judicial District, Sierra High School, and a few other community partners. Thank you for the question.
How do you engage with the rural areas of our area?
Good question. So I'm the Associate Director of Outreach. My supervisor, Nessa, couldn't make it today. Some of you may have met her before. Outreach is kind of a slow rolling ball. It always starts with a conversation, but just to get that conversation in the first place is not easy. So it can start with an introduction, email, phone call, or the most effective is face-to-face time and actually boots on the ground, which is what this grant is aimed to do, to actually get us in these communities. Being a virtual provider, it's difficult to build such an expanded reach. But over the past year, Vanessa and also the founders have built a network of over 300 partners that have either agreed to refer or actively refer partners to us. And we're no strangers to rural communities. We do a lot of work up in the northeastern part of the state, especially Weld County and Larimer County. Thank you for the question.
And yeah, the reason why I'm asking, obviously, is we've got El Paso County, which is huge, and then we've got our rural county to the west, Teller County that we serve. So just curious about how that outreach would be done.
Yeah, and we're also planning on attending and potentially hosting some high impact events to where we could bring people together and kind of foster what we call a community of hope. Try to bring people into the fold of our over 300 partner network.
There are additional questions?
Is your program for military families different, culturally different than it is for the other? You have two different programs?
Great question. So right now we offer fully virtual intensive outpatient and outpatient programs for 11 to 18-year-olds focused on mental health and substance use disorder and co-occurring disorders. And part of this grant would actually be for training our existing clinical staff in the cultural competency of how to deal with military families. And then also hire a clinician and peer mentor with specific military backgrounds so we could better tailor our programs to their needs.
Thank you.
Any additional questions, please?
Since you're working with teens in particular, and I'm very familiar with the laws here and that teens don't always have to have permission from parents to get involved with programs like this. But I think it's incredibly important and it increases success. So how do you involve families in the process?
Great question. I appreciate it. We believe in a holistic approach to treating teens for mental health and substance use disorder. We actually have parent coaching and family support groups, and they are highly involved in the communication of creating that treatment plan from the beginning. Unless there's some outstanding cases where the family can't be involved, it just depends case to case, but most typically they are highly involved. And like I said, we offer support for the entire family and parent coaching. Thank you.
Are there any final questions? Okay, we're not that.
Thank you.
Next, we have Serenity Farms.
Well, we can find out about you. You guys not do that?
You want to?
No,
I want to
sit
right here.
All
right, you guys, my name is Angela Wong. I'm the owner and operator of Serenity Paws, and I am also the founder of God's Dogs and Project Recovery. Project Recovery is our nonprofit, sub-specific program that we have. It's a 501(c)(3) C3 organization. And we take care of people's individuals, animals who are getting ready to go into detox, rehab, or a jail sentence that's under 90 days. While we're taking care of those animals, we are providing them, we're partnered with vets in the community, and we provide them with a wellness exam, spay or neuter service, mandatory vaccines from the state, and registration. once they're reunited, we are taking a work first stance. We are trying to hire those people at Serenity Paws. We have had 100% success rate with keeping the candidates that we have reunited. They have been working for a year right now. And I'm gonna hand this over to Jeffrey Frederick, who is also a part of this program.
Thank you. Yeah, so a big thing we focus on with that, the reuniting aspect afterwards is keeping those candidates, we like to call them candidates, in constant communication with their peer support groups. And that means a peer coach, that means even Angela directly, and then communicating with our transportation and logistical officers and others in their community. We actually have quite close ties with Achieve Whole Recovery. We know the people down at Serenity Recovery quite well as well. And Oxford Homes we work with to house them. Housing is one of the issues we are facing. En masse, most sober homes do not care for an ESA licensed pet, regardless of training. One of our programs that we do here is we help candidates put the power in their hands to train their pets to be example pets and their constant companion, and the reason why oftentimes they are getting sober in the first place. So that is a core issue that we face, is just spacing needed for our candidates to be with their pet, the sole reason for a lot of them that they aren't getting sober. And with that, I would love to open this floor up for questions.
Thank you.
I have a question. What does the relinquishment of the animal look like as far as how you measure the success of the person, and what is your maximum number that you can hold the animal if they don't pass?
Of course. Yeah, so great question. We actually deal with this very frequently. Our ideal candidate, and I believe it might be in your handouts here, one of the ways we define an ideal candidate is they go in for detox, they go in 3 to 5 days max. We take that dog in. The way that is facilitated is myself or a case manager and a peer service or a peer support specialist, apologies. We'll be in the room with the candidate and their dog, intake them, give them a friendly conversation, tell them how this is going to go. We let them free roam in the room. We have the doors locked. It's a quiet environment. The candidate is in a comfortable position. We offer them food, water, their dog's water, and let them play, bond with their dogs while we explain to them what the intake process is going to look like. Basically what that goes is once that candidate has signed all of our release of information paperwork, other relative paperwork that we would need for our files, we let that candidate go or give them a ride directly to detox. Once they enter our facility for an intake, they are consigning to the fact that they're going directly to detox or jail if that is where they're necessary. And at that point, we then we give the dogs a 15 to 20 minute walk for that onboarding process, just out back around the park with one of our trained dog trainers there. At which point they do return to the facility and they are kenneled in spacious kennels, plenty of room for them to stand up, turn around, play, romp, sleep, depending on the size of the dog, of course. We also do take cats. We will be open to other animals, but those are the only ones we service so far. Yeah.
So, but relinquishing them, because that actually has happened to us, because we had a gentleman that had some serious mental health and is incarcerated in quite some time. He's actually the picture on that brochure that's in there. His name is Walter. We have paperwork that they signed to relinquish those dogs and allow us to rehome them and put them in the best situation.
Yep.
And unfortunately, that does happen.
As far as the maximum amount of time goes, we shoot for about 90 days maximum. That's how much we can realistically reimburse. That being said, oftentimes outstanding circumstances exist. We still cater towards those. Our longest standing one, his name is Louis, he's a pit bull. We've had him for five months now. And that is well without our 90-day policy. But our focus is to keep those pets cared for as well.
Are there additional questions? Hearing none, thank you for your time.
Thank you.
Next up, we have Convergent Entry Skills Academy. Ryan, you have 3 minutes to present and tell me when we're going to move to the next slide. Hopefully so.
All right, thank you so much. And you're doing a great job. This isn't easy. You got the hardest gig in the room. This is serious business. We know the decisions made here will cause some people to live and some people to die. It's not a joke. And when I hear organizations like the ones that preceded me, and I know many of them and the ones that'll follow, there's just some fabulous work being done here. And I think that at the end of the day, that this group is assembled to do this much good with this much care is just so important. Many of you know us. We have a very simple precept. No one changes with all the efforts and money thrown at them unless that person wants to change. Isn't that true? Many things fail. Who have seen people fail? In the veterans world, we do work with Carmel, the Phoenix, what a great organization. I can't imagine that dog has saved lives, but I'm telling you that it's up to each individual person to do it. What makes that person decide to take advantage of the lifelines being thrown to them? That's what we're about. Convergent teaches classes. Many of you were involved in Concord know that even though we're not directly involved, I know I recognize some faces from the Concord world. We were invited at the to speak at the monthly meeting because of the effect our classes have on individuals. And if you can imagine hearing somebody know about how to drive a car and not give them the lessons necessary to practice the rules of the road, what a disaster it would be. We expect people under the triggers that bring opioid addiction back to that individual to navigate it by themselves. And if we haven't empowered that person, as you talked about, to take the controls in their own hands through cognitive thinking, they're going to fail. That's why our program is so effective, because we give people the tools so they're the farmer, we're the John Deere tractor. If you don't know how to think, if you don't know how to organize your life, you're going to be triggered. And so the populations we serve, people coming out of prisons extensively, people coming out of the military. I don't know what happened to our friends from Mount Carmel, but they're the same exact triggering events. The chemical rewiring that people who have suffered from opioid addiction is so powerful that individuals barely have the ability to control their impulses. If they don't have a track to run on, if they're not given the tools, they will fail. We've talked about the cost of recidivism, the destruction of families. Certainly, it isn't hard. The district attorney certainly knows the cost of incarcerating people. The cost of a person going to trial is the least of it. Think about that child whose mother is in prison. We're talking to Human Services. We were at the Veterans Trauma Court last week. Our program works because if you give the individual the ability to flip the switch, her or himself, then things can really change. Then the rest of it falls into place. Without that, it all fails. I know from talking to so many of you on a one-on-one basis, from law enforcement, behavioral sciences, halfway homes, therapies like the great program you're doing with the animals, the wonderful work the Phoenix does, and UCC, what can we say about you people? I mean, it's just terrific work. But if that individual is hopeless and feels sometimes a time bomb years later, the trauma of being in battle, the trauma of having your identity in the military on your sleeve and then being forced to reenter without the ability to turn it around is almost completely fatal. And if you talk about the distinction between recidivism of people who don't have this kind of cognitive thinking course, and a community peer support is very important, but the individual has to be given the tools and the responsibility. Again, I use the metaphor, they're the farmer, we're the John Deere tractor. But it's a foolish person who isn't smart enough to want to give up tilling by hand if they can get their hands on a tractor. That is why just a few months of this kind of work makes such a huge difference. So the Franklin Covey organization reached out to us to develop programs specifically for people for reentry, a specific population of sex offenders. That's a subgroup, people coming back to society through prisons, people returning from the military, human services, domestic violence victims, people who have been through trauma need to know that they can think their way through this, that there's a pattern of thought, there's an ability to separate the stimulus from the response. And you can see it in the numbers. We virtually never hear someone who has successfully completed the training having a problem again. We talked about the 15-year journey of your friend. That's the journey we like to start people on. So we're asking a big ask. Here we are teaching people something, but let's see. I think there's one more slide, or did it proceed? Okay. It's triggers that send folks back to addiction. It is a trigger that will always occur. There'll be a day when your spouse is mad at you, or the kids are upset, or the boss is a jerk, where you barely have enough money, your tire goes flat, you have to buy a retread just to get to work, and the retread blows 30 feet down the road. All of it will happen. It isn't that it might happen. Triggers occur from family conflict, if you don't know how to communicate among the family, from work conflict, if you haven't learned the soft skills. You're in a big organization. I bet there's conflict there, and it isn't from people who are addicted. It's human nature. This is the change. These are the tools. They now call it soft skills. We used to just know how to talk to one another. But if you don't know how to mitigate an argument with a teenage child, anybody here have teenagers at home? Okay, so it gets better. I've got 6 kids, and all of them have done well, and the youngest of the 6 is now 27. So I'm out of it, but there was a period of time. So we have a big ask. It would be a 50% increase in our budget, but it would allow us to extend the reach to everyone coming out of prison. We deal a lot with DOC and probation, the courts, parole. We like people to be armed with the information they need to navigate the biggest pressure point of their lives.
So that will open up questions.
Yes.
Can you speak a little bit to how it increases your impact? If it's a 50% increase to your budget, is that you're able to hire more staff?
Yes, thank you. The one thing, and many of you have housed us in various ways, including the workforce centers and the Concord organizations, and we've been to most of the paroles or probation. We could have a headquarters here. It makes a huge difference because we get calls all the time. I have somebody, he just got out, we need to send him immediately to meet with one of your people. All of our people are double certified trainers in what in prison is called 7 Habits on the Inside. It was developed by a man named Jeff Carney, who is a native Coloradan. He was one of the first hires 40 years ago. And if any of you have a DOC background, you know that in years of no budget at all, they have just renewed again 3 more years for the officer corps, 3 more years for the inmate corps. That is sandlot baseball compared to the major league ball that we teach. We do it as the corporation would if you were hired by a large bank or a multinational. And we make sure the books are read, homework is done, it's internalized, no joke. We see it as saving people's lives. We know it has. You got the B team today with me, but in the slide there, you see Gino Vilas is in surgery right now. So I could not say, don't pull this on me, Gino. He will be all right, I hope. But he was serving a client, a dog attacked him and ripped his lip off. And our numbers woman is her grandma's funeral was today. So you got stuck with me. But Gino had life without parole. He'll tell his story. Many of you have heard him speak at other events. Life without parole, expected to die in prison. And he was put through this very important, but I have to say, lightweight version of what we teach. While in prison, it went in one ear and out the other. I'm sure the DA is familiar with the program, right? He didn't listen at all, but one of the officers there believed he had something inside him. And a few years later, that officer told him to take another one of their courses called Sharpen the Saw. This time it took, and the Justice Integrity Unit went to court from, I think it was Jefferson County, along with the defense, and made a joint motion that got Gino released. That's the kind of conduct he had. He compares it, if he were telling the story, his first 10 years being a knucklehead, drug use, tattoos, every other thing, to the last, he did 27 years. His last 17 years where he was in every program, the arts, and was the kind of person where the district attorney joined with the defense counsel to free him. That came from a lightweight version of what we teach. The effect is enormous.
I just still would like to understand what your sustainability plan is, that if it's to help you open a facility in El Paso County, is this funding going towards capital? Or I'm assuming you're going to have to staff.
No, it would be a 50, it's all for outreach. Virtually 100% of it would be for outreach. And the distinction is, very good question and very bad answer on my part. The distinction is we have some experience now on getting the program done through the internet, where people are given tablets and they're able to join that way. And not only assembly in halfway houses, Comcore, sober living homes, but where a parole officer or probation officer can say, you must take this this course. We can deliver the tablet. It's a different dynamic, but we're trained to do it, and we've had some great success. This really works for human services when you might have a single mother who doesn't have the ability to manage all the aspects of her household, handle the conflict in her life, but she also doesn't have the ability to get on a bus or take a car and assemble a couple times a week, that's a tremendous burden for that family. And so that's where the investment would go. That's why I think they said that the outreach would be exponentially larger. And anybody in business knows that often the last 10% increases your reach by 40 or 50%, and it's also true here.
I just have a comment and a question. It's been brought up a couple times. So the cost of housing an inmate is $144 per day. And right now we have 1,300 inmates. So obviously our goal is to reduce the recidivism. Where do you get your client list?
Well, for example, the DOC, all their outreach navigators would call us and give us that complete list. Courts, probation officers, more and more courts as they learn of the program for diversion would require it. DOC is looking at changing parole so that cognitive courses like ours are required. And you're quite right. It's almost you say $144 a day. You're right, absolutely. But isn't it more like over $100,000 a year if you consider the social safety net for a mother incarcerated or a father incarcerated and the burdens on the rest of the family and society? Someone earlier mentioned somebody who was now paying taxes instead of being in prison, who perhaps is an entrepreneur employing people. The incalculable change in someone's ability to beat opioids by knowing that the label on them is the wrong label. And that's where it starts. If you change that label, you change the person, the self label. I think I've just seen it so many times. If you could talk to these, it's mainly men, but often women, talk about their being back in touch with their families, holding a job, having the courage to get to the other resources like NA or AA or church or synagogue, getting back to community. What Silver Keys does is amazing to prevent isolation. This is another way to do that. Human beings don't make it on their own. The numbers work here. The social cost is great, but the change in people's lives is what we're talking about. Help us save thousands of more lives.
Okay, any additional questions? Okay, hearing none, thank you.
Thank you.
For your time. Next presenter is CEC Analytics. Reminder, you got 3 minutes for the opening comments. I would like to
Yeah, well, with I know when to talk, so I apologize. I'm going to try to keep count to 3 minutes and respectful time. Thank you for having me today, and I really want to thank the time that was spent to review the proposal. We take a very unique approach to fentanyl and opioid challenges. And we look at a medium source that is often overlooked, and that's wastewater. So wastewater epidemiology has been a practice that's been used for decades and has been really a hyper-focused attention really for COVID-19. High track opioids and fentanyls. Our data sets range between 8 to 18,000 compounds in one sample source. I can see new synthetic opioids entering into communities before we actually see toxicity of morgues and people's deaths. At the headquarters in Calgary, Alberta, Canada, we actually do drug paraphernalia testing. So back to the comment about the marijuana laced with fentanyl, we see that. We see carfentanil, remifentanil, sufentanil, we see norfentanil, we see opioids.
poisoning agents like xylazine, nitazines. We see methamphetamines, we see cocaine, we see accelerants, we see all these different types of compounds that tell a story of the overall health in our community. Unlike COVID-19, we actually use this data to estimate the consumption of drugs within our community. And by looking at data, we're actually able to use this as a KPI about how effective these programs really are. How much naloxone do you actually need to deploy on boots on the ground? How much naloxone do you need to distribute to wet homeless shelters within the city? And we have proven that this is very successful. Unfortunately, to this day, we have benzodiazepines and the fentanyl supply. You require a lot more naloxone to be administered, up to about 8 to 10 times. That's a huge economic burden from a municipality standpoint. So if we're able to get ahead of it, actually understand what's in the drug supply, we can proactively look at different strategies to implement. We have quite a lot of experience in this field. I myself have about 15 years of experience. We work with VA, the DoD, we work with Health Canada, we work with NATO, EU, we're in 4 continents around the world. We track opioids and pharmaceuticals in hospitals. We track pharmaceuticals and opioids in homeless shelters. We track all these different types of emerging compounds that tell a story with our communities. Here's actually a data set from a homeless shelter, and we can track fentanyl usage, total overdoses, and the amount of naloxone actually being used per overdose. We can see this all in the water. The proposed project that we're proposing for both counties. Sure, as well.
I just advanced the slide.
Oh, fantastic. I think we're good for time too. One more minute, okay. This is actually really simple to do, these programs. Takes 1 sample. We are proposing that samples are going to be collected from 3 wastewater treatment plants. 1 in Woodland Park and here 2 wastewater treatment plants. So we have a coverage of about 430,000 people in 2 counties. And we're able to actually estimate how much fentanyl is being used with communities. So here's our cost. It's $94,000 to $19.64 per year. Samples will be collected on Monday, every single week from each facility, and we already have MOUs in place to get this project kickstarted. So we are amped, we're ready to go, and we are excited to help.
So with that, we'll open it up for questions. Commissioner Geithner.
Okay, so a couple of questions. So you said MOUs with each facility. So what facilities are you referring to?
Woodland Park.
And Woodland Park.
Yes.
Okay. And so obviously, you know, the thing about El Paso County in particular, and I'm guessing Teller is somewhat, but I'm not as familiar with we obviously have CSU, College Springs Utilities that provides wastewater for the majority of the city, but much more complicated when we get out in the unincorporated county areas where we have a lot of different metro districts, so there potentially could be a lot. So in terms of what does that do when we're talking about cost, if we really were trying to get, you know, an assessment across El Paso County?
Yeah, not a problem. So we actually have broken this up per system per year.
Okay.
So we just have a multiplier.
So when you say per system.
Per location.
Per location, okay,
Yeah.
that's what I was getting to, is what those,
It's a great question.
actually, okay.
Yeah, it's a great question.
And then help me, the part that I'm actually, not sure about is how this fits well into this particular, bucket that we're looking at. Would you just speak to how you see that fitting into this? I love the concept as an objective measurement. It's very difficult, obviously, to find many of those in this space, but how do you see it truly fitting into that?
Good question. So we can use this data as correlation of active programs. Do they work, yes or no, in particular areas within the city? We're able to actually notify response teams that there's a new fentanyl derivative in the drug supply actually happening. So we're able to proactively identify personal protective equipment, how much naloxone is required. We have seen this data actually being used at facilities that homeless shelters, emergency shelters. For resource distribution within the municipality, we also see that as well. So it's a lot of the education that comes with it, and this notification proactively that say, hey, we've got a problem. In this proposed project, we have proposed a monthly reporting schedule. I can assure you from what we are finding in the wastewater from all our projects across the United States and Canada, that frequency is probably on a weekly basis, just based off what we're finding in the return supply. If we see carfentanil rising, we're going to notify the stakeholders. You have a serious problem. Please notify the organizations to be aware of this. So a lot of the education piece.
Any additional questions, please?
I have a couple of questions, Vicky. Can you give a little bit of a few examples of, well, let me first ask, how many years have you been operating? And because you've named several different entities that you work with, so let me just understand how long.
I founded the company in 2020 in spring.
Okay.
My PhD was actually in this field, so I have about 15 years of experience.
Okay, so then what would be an example of a response that you have seen from the community where you gave them this data? Hey, we're seeing an increase. How were they able to act on that information?
Great question. So, again, homeless shelters are a very good example of this. They have restocked naloxone immediately. They have talked to one another and all their organizations where a transit population visit and actually receive services. So we are aware and notify the people and also the personnel responding to these events to wear specific equipment. So we had an instance where we had benzodiazepine levomisol found in the wastewater, and we saw a correlation between overdoses occurring. And so we actually created a high alert call. So it goes across all organizations that says, we see levomisol in the drug supply, please be advised. You will see opioid overdoses occurring in your community. Please make sure that you have necessary resources ahead of time. So that was a very good case. Interesting, I mean, this is a little bit different, but in terms of other parameters like infectious diseases, we've seen operations being, completely steady state by bringing in contractors to offset potential sick full-time employees. And so the use of this data is really important for operations.
So can you repeat, I think I missed it. You mentioned you have an MOU in Woodland Park, and those are where the 3 sites are?
Oh, Woodland Park has one.
Okay, so where were the other 2?
Right here. Yeah, so that's correct.
Do you know off the top of your head if it was a specific metro district or with CSU utilities?
CSU, yeah. We have a wastewater treatment plant that covers the north section and the south section. So we have reached out, we haven't got that MOU signed, but they are aware that we are proposed to. That's right.
I'm just thinking about how you said like homeless shelters. I mean, that seems really very site specific. And so how do you drill down and they're serving a broader community, and how would we utilize that in our community at, say, our fire response rescue mission?
Yeah.
They gain that information.
Absolutely. So I think that's one of the interesting benefits of wastewater technology is that we are able to actually track and be more granular than needed. So our firm specializes in facility-based monitoring. And so we have expertise of actually implementing the same programs as at a shelter or at a facility. We start with the city, we understand what the issues are, what the challenges are, and then we look through of what all these facilities could be. And then we simply can expand on this program or adapt the program.
How do you partner with entities like a Department of Public Health, for example?
Yeah, so I think it's all part of the notification. If we're seeing that something in the drug supply that is cause of concern, we're going to be notifying stakeholders already identified for this program even starts.
So is that, I guess, what, like, where would they come in if you have an MOU established with the Colorado Springs utilities? Are you proactively then reaching out to the County Department of Health, saying, hey, we now have these contracts, we're going to do screening, we're going to police number, and so we will proactively notify you.
That's right.
Our results are.
Yeah, and that's part of the program, for project management.
Okay, thank you. That's all my questions.
One more question.
Do you have an agreement with Colorado Springs Utilities?
Yeah. No. So we reached out to the both utilities, both wastewater treatment plants. So they are aware that this program is being proposed. So we've already made contact, but we haven't got a response back yet.
And more of a comment, I understand the ask and what the ask is for, but just because there's an increase in a particular benzo or fentanyl in the community doesn't mean that shelter has the money to add the more resources. So there's a disconnect there for me because yes, we may see an increase in something. And you can notify them, but they don't have the resource to implement it. That causes a whole nother problem.
Right.
So actually, a direct line to opioid. Lessen the opioid abuse or suicide prevention or whatever. To me, I still don't see the connection to the funds.
Okay. So we can use the data for many different things like resource distribution, adding more naloxone and pointing where locations are within the city to actually place more naloxone kits, for example, fentanyl. In terms of a benzodiazepine appearing within wastewater, we're able to notify stakeholders that this is a concern. Please be aware. You're going to project ahead overdoses occurring on site. It's more of an awareness or more of an educational piece, more of a communication strategy between stakeholders that this is occurring. Things are shifting within the drug supply. Resource constraints, we see this all the time within facilities. I think it's about working together. Perhaps one facility has a little bit more resources to spare. And so there's that sharing of information that we've seen before that's really helped out.
Yeah, you're assuming that it moves fast, but government moves very slow. We all in here know that.
Yeah, absolutely. Yeah.
Thank you.
I have an additional question.
So I'm not sure exactly what the population is as far as rural to municipality, El Paso County. For Teller County, we're about 28,000 people for population, and that's year round. That doesn't increase. However, the population of just Brooklyn Park is roughly right around 7,500 to 8,000 people. So that's a smaller percentage of the entire county as a whole. So you're kind of taking a smaller data point. And I actually absolutely see how this would be incredibly beneficial, not just for public health, but also for the law enforcement aspect and medical aspect as far as tracking, because this is how we can show, okay, we've had a reduce in overdoses. We've also had a reduce in the amount of fentanyl we're seeing in wastewater treatment. But just trying to wrap my head around to kind of piggyback off of what Carrie was saying, how are we going to reach the rural part of the county that is running out the septic system? How are we going to be able to measure that? So this is kind of one tool that I think we could absolutely use, but it's kind of tricky for sure. So
septic systems are the trickiest part, I would say. I would not suggest sampling those locations. I think it's interesting to say the least. It's very challenging and resource constraint or resource high intensity resources and economics just doesn't make any sense. What really we are looking at is where is the highest density population, maximum coverage that they can possibly get. And so this is why we chose that location. There are, like I said before, there are facilities that we can expand into and pick and choose. As part of the adaptation and the modifications of the project. So,
have you thought about reaching out to Bacon Creek, for example, with their wastewater treatment plant? Because we have a lot of tourism that occurs there due to casinos. So you see some interesting numbers, I'm sure, coming out of Cripple Creek compared to Woodland Park and possibly even compared to Colorado Springs.
Yeah, no, absolutely. We can definitely do that. Really, any system that collects wastewater, we can analyze, no matter how small it is and no matter how big it is. And we can use that same practices. One of the other comments and parameters is actually alcohol. We can actually estimate the consumption of alcohol based off metabolites and wastewater. So it's not just about fentanyl. We understand this is a very complex polysubstance, problem that we're seeing. And so is our diversity of our compounds. So alcohol is another one, casinos. Yeah.
You're gonna get a lot of false negatives out of Cripple Creek. Or false positives.
I appreciate this. I'm gonna just kind of make a statement here, so I'm sorry for that, but I still, because you asked them the same questions, I hear what you're saying about education awareness. It's kind of an internal. I think my vision of this bucket, which could just be me, is community prevention, education, and awareness. That the education awareness would be focused outwardly on citizens becoming educated and aware of the problem in order to create that prevention. So I think that's what I was trying to
Sure.
understand is why you applied in this bucket. I don't think it fits in this bucket personally. However, I still think it's a valuable tool and I'm not sure exactly where it would fit or if maybe it is something that we would just consider contracting for even as an objective metric for us to follow as a group. I would also say, to your point of so many different things that can be measured, I know, I'm fascinated by this. Because it's so difficult to find those objective measurements. But I would ask maybe, Dan as well from public health and from the teller folks. I thought you were back there. From a public health perspective to think about, both how this could be used for that and other things. And I wonder if there could be even kind of a partnership, if this is something that would benefit our community as a whole. To be able to take this data and work on it from this perspective, but also maybe there's other valuable, perspectives to come from. So I just, in preparation for maybe future discussion on this, is if it doesn't fit inside of this bucket cleanly, are there other interests and what ideas you might have about how this could be utilized, or anybody in the room? Those were just kind of my thoughts, so.
I appreciate that. This is a very complex issue and a very difficult subject. I could take the entire day talking about this, trust me on that one. So I'm happy to have other conversations, well, to see how we can develop a program that this needs, so.
Yeah, I also would like to make a comment, and I think we're on the same page here. I think it's super interesting science. And from a very high level, it tells us it's in our community, and if we we're gonna do an action plan, like let's put together a campaign to reduce this particular thing and then measure that by monitoring water supply. I think a big public campaign like that, we could really ascertain the results very, very well. But at a actionable level on the ground, it's much more difficult to do that. So to be able to say, we see this, and so therefore we're gonna take these specific, more micro level actions within our community, within the people who are using substances, with the individuals at the mission or the individuals living on the street. It's more difficult to translate it that way. And to do so, you'd probably have to get more access into deeper levels, like go in and start sampling the rescue mission. And even then the question, that was already pointed out, and what would they then do with that? How would they then be able to support that? So yeah, I can see a level very high where it'd be very helpful. Doesn't translate down to the actionable on the stream level where a lot of this stuff is.
Yeah, so I guess I hear what you guys are saying. I see this as you're helping to give information to those that then act. So you're helping them prioritize their resources. If we see an influx in our community of something, that then it is a way to know, like if it's the Department of Public Health, oh, we better start prioritizing messaging out to the community on, like, maybe it's to schools or something like that, of we're seeing an increase in drug usage overall, whatever it might be. So I see it as, I don't know what bucket that would be. I can see that it's youth prevention or community prevention, but it's more of just helping gain insight into where we need to be prioritizing our efforts and our resources. But I did have a question on your, oh, hold on. Your accuracy rate. Can you explain a little about that? How accurate is this data?
It is extraordinarily accurate.
Okay.
We were talking like PPT, so parts per trillion.
Okay.
So,
I'm just saying the fact that you're like smiling so much about this.
Love this, literally. Yeah, no, we can see trace minute amounts of drugs in the water supply. So think of how much volume that is processed in a wastewater treatment plant, and we can still find trace amounts of carcinogens.
And that you're accurately identifying in the compound, that it truly is fentanyl, or we truly are seeing an increase in XYZ.
We use chemical surrogates to confirm that. I look at it as a chemical fingerprint of your doing.
Any other questions?
It's not really a question, but just a comment. So
I think my biggest concern is that you've identified 3 locations, but you've only got an MOU for 1 location. And I think you've said that your other 2 locations are here in Springs and they haven't gotten back to you.
Yeah.
So I'm just not quite sure that we even have established what area you're going to serve at.
Yeah, so they are interested. We sent out the MOU back in first, did the application, so submission, that was in January, I believe, this year. So we wanted to wait until there was a position to actually, you know, present this project before we actually then go back and say, hey, how's that MOU coming along? I know that there was interest before, there still is, I can assure you on that. It's just a matter of just signing the document, so.
Would you be moving forward with the MOUs if you were not awarded this?
Sure.
Would you be still moving forward on those MOUs if you were not awarded the grant?
I would, yeah, absolutely. We have 50 wastewater treatment plants across this country, increasing to 500 by year end. Trying to be exact, specific. Every single municipality that we talk to is interested in this. Because it's data is ridiculous to make actionable decisions. So yeah, absolutely, I would still go forward with this project.
Kind of interesting that this could be an opportunity for our community to see if this is a worthwhile thing to continue. Like it's sort of, it's very innovative and that's part of this council, right? So if before we spend recurring dollars on something like this, it could be a test or trial run to see if we find value in this data to then want to continue it in the future or not.
Yeah, I think it's a great question. So we propose a 1-year program. We can do 6. By 1 month, you'll have enough data to actually show value levels.
Any other questions? Okay, thank you very much.
Thank you.
Appreciate that. We'll go to the next presenter. I think it's the final presenter as well, and that is Step Springs.
I'm here, I live through, just have a little traffic jam.
Listen. As a reminder.
Okay. Thank you. I'm Megan Shea. I am the Executive Director of Step Springs, and the timing of this is perfect as we are right at our completion date for construction of what will be a 50-bed residential facility. I don't want to jump the gun. I'll start with our mission because we are new to the community. Our mission is to give men with nowhere else to turn the opportunity to overcome addiction through sobriety, work, accountability, and community. I am sure you are all well aware that just in El Paso County alone, 69% of all drug overdoses are male. As a woman, I often get the question, why do you specifically serve men? And we really pride ourselves on specializing and serving the population that has the greatest need for our mission, which are men who not only are struggling with addiction, but have also faced every consequence imaginable as a result of that addiction. We all know the consequences of losing family support, losing jobs, losing housing, right? Losing all sorts of things and ultimately ending up in many cases homeless in our community. Actually last year, so I should start with why we're coming to Colorado Springs. Step Denver, I don't know if you've heard of Step Denver, has been serving that community since 1983. We were founded in that year on Larimer Street, 2 blocks from Forest Field. To this day, we are on that block and we are surrounded by bars. We're the only building on the block not serving alcohol, interestingly. And so we now have a 42-year track record, 10 years worth of solid data, outcomes data, to prove that this model is effective, that it works, that it is a real proven solution to these issues. And for years, we have been hearing from leaders in the Colorado Springs community, both elected officials and business leaders in the community telling us that there's a need. We've also been hearing from funders, some of the most significant foundations in our community here, telling STEP there is a significant gap and we really need a STEP program in Colorado Springs. What I would like to say is, I want to thank those of you, I see Beth right there, from Homeward Pikes Peak. There are individuals in this room who were instrumental in our decision to answer that call. Because as we heard from those funders,
we, said, great, they think there's a need for us, but what do the people who are boots on the ground doing the work say? Do they see a need? And we wanted confirmation that we weren't duplicating services and that we were bringing something truly new to the community. So 2.5 years ago, we made the decision to take this on, and I'm very grateful to share that we just completed a $6.5 million capital campaign, taking on no debt. And so you'll see in the request that at the time we submitted this proposal, it was actually a blended ask for capital and program support. And I'm grateful to share that now any funds that may be awarded to Step Springs will be utilized 100% for direct service. I'm sorry, can we go back one? So we're building a 50-bed residential facility near I-25 and Garden of God's Road. Our program is addiction recovery, but with life skills and workforce development blended in so that men can rebuild their lives, not just achieve sobriety, but be able to repair all of that damage and build a strong foundation. We're projected to serve 160 to 200 men annually. That 160 is based on a 35-bed average occupancy. Or capacity, I should say, in a 50-bed facility. So if we serve the number of people that we anticipate based on all of the providers in the community telling us that we will have a waiting list, that number will be much higher, but we want to be really conservative in our projections. So that's if we had 35 beds filled on average at any time. Our historical outcomes in Step Denver, we measure our economic impact based on follow-up contacts of those who are still sober, employed, and housed. And based on those figures, it's projected that Step Springs will have a $23.6 million local economic impact in the first 5 years. Now I'm ready. Thank you. So it's a unique model for a couple of reasons. The first of which is that we provide same-day, no-cost intake for any man who is ready and willing. So there's no cost. If you're ready, you're coming in the same day. We know that window of willingness and readiness is pretty small. We also know there's a strong pull in the other direction, so we act quickly getting men in. We hold men accountable, meaning we treat our residents like the grown, capable men that they are, which, by the way, restores their dignity. One day I was in the dining room and a gentleman looked at me and he said, "You know what I love about this place? You treat me like a grown man." And so we really believe that accountability is critical in the recovery process and in life. We take no government funding, meaning we are not contracting with any government institutions. We're not billing Medicaid. We are not even billing insurance. We are entirely privately funded. I'm happy to answer questions about that at any point. But the other key here is that the men that we're serving don't either. Many of them have been in the cycle of dependency because of their addiction for many years. And what we're doing is breaking that cycle of dependency. We're providing all of their basic needs when they come in. They have a safe, sober place to live. They have food, clothing, hygiene items, all of these services to help them rebuild. They are not going to have to live in a state of crisis or survival mode anymore. And as a result, we are requiring that they are no longer taking government benefits and that they are working towards self-sufficiency and true independence. On that note, we're restoring self-sufficiency. We're providing an off-ramp from third-party aid and ending that cycle of dependency. And the key difference that really I think sets Step apart, in my view, having done this work for 21 years, is that our men are building a foundation through action. They're not insulated from the trials of life. They're applying the tools in real time. So what that means is they're going out to the community and getting full-time tax-paying jobs. All of our programming happens between 4 and 9 p.m. So they come home from that job, participate in all of our addiction recovery and life skills programming, learn what they need to go out and apply it the next day, and they're building a solid foundation that leads to real outcomes. I will tell you, last year, being in a building surrounded by bars and open air drug use, having men go out to the community every single day, facing stress and temptation, only 6% of the 382 men that we served relapsed during their stay. And our program is conducted by those who've lived it. Over 70% of our staff are graduates of STEP's program. I like to tell them, you are uniquely qualified. You are an expert. You know better than anyone what it takes to be able to overcome addiction, have lasting sobriety, and rebuild your life. And so all of our program staff are people who've been through our program and are living proof of what's possible. Outcomes, really important outcomes. Actually, I've shared this is our alum, Robert, who just celebrated 4 years of sobriety on July 4th. And you can just see in his eyes what this program does for people. But we really pride ourselves on focusing on outcomes rather than just services. We actually don't even consider someone a man served, meaning they're not showing up in our count of men served until they've been in our program more than 5 days. Did we provide free housing? Yes. Did we provide a whole host of addiction recovery programming, peer coaching, career counseling, all of those things? Yes. But we are in the mission of outcomes. We want our men to be able to sustain all that they rebuild, most importantly, their sobriety when they leave. We follow up with men at 8 different intervals in the first 12 months after they leave our program. Last year, our contact rate was 85%. That includes both people who leave our program successfully and those who leave our program classified as unsuccessful. We are still following up with them at those 8 different intervals in the 12 months after they leave our program. Last year, of those follow-up contacts, we were able to reach 140 men in follow-up contacts in the 12 months after they left. 85% were still sober, 75% were still employed, and 90% were still housed. So this program works. We are very grateful to be able to be of service to this community. We know the sense of urgency. We know the shortage of beds for people in need of treatment. And we have a very cost-effective solution that is proven to have outcomes, and we are just here to be of service. Very grateful for your time. Happy to answer any questions.
So that opens up a question. So Councilman.
You're opening down here when it's coming up
Oh,
soon.
so construction completion September 19. We're hoping we can start moving furniture in. And we hope to open our doors by the last week in October or the first week in November. It really depends on how quickly we can prepare the facility. All of our staff have already been hired. They're currently in immersive training in the Denver program so that they can have that hands-on experience and be ready to welcome those new residents in.
Well, I just want to say, regardless of what happened with the vote, thank you for opening up down here. I've been a big believer in your program and what you've done in the Denver area, so I hope it's as successful down here as it has been there. So thank you.
That's our intention and our mission that we will make sure of it. And we really have invested in that 2 months of training with all the staff. That's obviously an expense and we don't have doors open yet, but we think it's really important that the men coming in brand new have the same quality experience as someone walking into a 42-year program.
So
you said you can come back around. I'm just curious, you've been doing it for 40 some years, so you're doing it great. But how do you generate that funding piece to sustain when you're not billing anybody?
I'll be honest, it's difficult. It's a grind. It's hard work, fundraising. So I will say that once the men get a full-time tax-paying job, which we help them get through our career center, they start paying program fees. It's $200 a month in phase 1, $225 a month in phase 2, and $300 a month in phase 3. So the most they're ever paying when they're in this facility is $300 a month. We focus on them saving for their future. We require them to put 20% of their gross income into savings so they have that healthy nest egg and can transition to independent housing. That was 11% of our revenue last year. So it helps. It's not nothing, but it's 11%. The remainder is fundraising. So of the fundraising pool, 24% last year was private foundation grants. 3% was corporate partnerships, and the remainder were individuals. And so we have just over 3,000 individuals in Denver who just give what they can. Denver's annual operating budget is 2.6 million. Our operating budget for Step Springs is in the full year. This will be a partial year, so it's not quite, but in a full year will be 1.4 million. And so we are fundraising and building that base. And that's why this support would be so critical for us, because we are building that runway, which takes time to establish a donor base like that. And so this would really allow us to have that runway to do that work so that we can, as an organization, become self-sufficient, meaning the community is supporting this program.
Obviously, you're very aware we're here. I know, exactly. We were just in the last meeting.
Yeah.
We're obviously a large military location. How do you plan to work with our military partners that are all working in this area?
From the outset, we've actually set that as a stated goal for us. In Denver, we only serve only 4% of the men that we serve are veterans. And so it's a really small percentage of the total. Being that we are in a community that has a large number of veterans, we've actually made that an intentional goal. We've hired a full-time outreach coordinator who will spend their all day, every day, going out into the community to reach men who need our help. And I have been meeting with providers who specialize in serving veterans, and that individual will be making those rounds and connecting with them to try to facilitate any veterans having immediate access to our program. So I don't have any data to share yet other than intentional effort and a goal that we've set to really make that a significant portion of the population we're serving. We hope, should they want this program.
Other questions?
I just have a comment for feedback, because I have been and toured the center in Denver and have seen the tremendous work that is on here. Thank you for your presentation. It is phenomenal, which of course I expect nothing less, but phenomenal. And it's just so refreshing to see those follow-up contacts, what you all do. And we ask these questions of every applicant, and there's often, and I understand that it is difficult, we get a lot of like, oh, that's hard. People don't respond very well. And so, the fact that you do consistently follow up and make sure that those outcomes are there and are sharing those with us is very refreshing. So thank you for all your work.
Thank you. I do want to just briefly give credit to those making the calls. The reason we have an 85% contact rate, which was a record for us last year, year before it was 79%, but it's because the person making the call is the peer recovery coach, the recovery support manager, the person that this individual has been working with from day one-on-one. And so there is respect and trust and love. And when that person calls, the individual, the alum, the person who is no longer in our program is more likely to answer and more likely to be honest. And that is also another coaching moment for us. Should someone not be sober and be struggling again, then we can help them get back into either our program or to another program. So we see it not just as data collection, but this is important to us, accountability and seeing how it works so we can adjust as needed, but it's also additional peer coaching.
Maybe it's the best and I missed it. What's the average length of stay of someone in your facility?
I didn't say it, so you didn't miss it. Average length of stay is 4 to 6 months in the primary facility. We will be working to add sober living homes. In Denver, we have 6 sober living homes, 30 sober living home beds in addition to the primary facility. That will be the next phase of this work. But they would stay in our primary facility 4 to 6 months, then move to sober living where they can live for 18 months, some longer if they need it. I will say that the average length of stay for individuals who do not go past phase 1 of our program is 22 days. So there's a small segment of the population we serve where we are planting seeds. And what we find in our outcomes, because we follow up with those individuals too, is that they do take root. But for those who get past phase 1, their average length of stay is 187 days. So that's of all the people we serve, but the actual program average length of stay that we encourage people to participate in is 4 to 6 months.
Do you have people that try it in for a few days, leave, and then come back and try again?
Yes, and that's why we don't count them in the men served. Yeah, obviously we served them, but we want to know that we did something, that we provided enough of the planting seeds that there actually is an opportunity for them to have success after they leave. And just stabilizing someone doesn't feel like that to us, although it's still important work. I will say you have to wait 6 months to reapply for our program because we do not want to be a revolving door. Prior to us having this in place, I will tell you, STEP years ago, 10+ years ago, was a revolving door because anyone who is suffering this disease is going to have a moment where they say, you know what, I'll go back out and I'll come back in a couple weeks. And if you allow that, they will make that choice. And I think that our 6% relapse rate shows that the serious consequence of I can't reapply for 6 months actually leads to people making a different choice. And so that is a requirement. If someone were to come back after 3 days and want help, of course, we're going to help them navigate getting to other programs. But we're really disciplined about making sure that that window is held.
How long will the 500,000 sustain you, or what exactly is that money?
It will be for program support for year 1 specifically. So it's a $1.4 million operating budget. I will say, proudly and gratefully that STEP Denver, which is a separate 501c3, separate financials, accounting, all of that, really has been working hard over the years to put money away for mission-specific growth. With this in mind, we can take this program and bring it to other communities that have significant needs. We contributed $3 million towards the capital project and are contributing $1.5 million, 500,000 per year over the first 3 years to help support that runway until Colorado Springs is able to support this program on its own. So Step Denver has contributed $4.5 million of hard-earned funds raised for mission-specific growth to support this. We have some other support from Horse Foundation, GE Johnson Foundation, Colorado Springs Health Foundation, and Credit Union. Yeah, so it's coming together. But this would be critical for us at this moment because we have a $625,000 gap in our funding for year one. We're actively fundraising. We have full confidence based on our historical fundraising track record. We'll be able to do that. But this really is a critical moment for us and would give us the stability that we need to put our focus where it needs to be, which is the member survey.
Any final questions?
No, I just have a comment. I also attended or went into
Yes,
an interview or an interview. Oh my gosh, not an interview. Did a. I toured as well.
Yes.
And it is very structured and it is very, they are very accountable for, I mean, they have to make their beds a certain way in the morning. They each have refrigerators, they have to buy their own food, they have to cook their own food. And I'm like, hey, can my husband just come for a week?
Oh, we get that request all the
We can make
time.
his bed. I'm kidding.
And teenagers. People often want to say that.
But to your point, it is, I love that there's accountability. There's respect. There's accountability, like there's so much more when you tour than what you could say. So I just wanted to throw in those other little things. There's a gym where there's health involved where you need to be healthy, you need to be strong, like the mind, physical, body. I think it is all of that in a nutshell of what you said. I also am so glad it's down here. Partnering with Beth is the best thing you could do.
Yes, we feel that too. She's been such a great support.
So I'm really glad it's down here and that you got through all your
I know.
planning
It's a
issues. I had
marathon.
to help them and
Yes, you did. Thank you.
I need that wire in.
I
Get
know.
it.
It's true. Yes, we were, there's moments that are scary in this process where you do all this work and you raise all these funds and then you still are counting.
You're
on
not
things
zoned right.
being
Exactly.
approved, right? But yes, it's very holistic. We have nutrition, fitness, meditation, acupuncture to help with the post-acute withdrawal symptoms, 7 habits of highly effective people, family reconciliation groups. I mean, it's very holistic. In
Monday
addition
night
to the
football, Super Bowl.
all these social and recreational activities, all of it. In addition to that, one-on-one peer coaching, our small group curriculum, which we have 26 different small groups that are addiction recovery groups that our staff lead, and the career counseling piece. We really view these as being connected, but just having sobriety, you come out of a treatment program and you're in this little bubble, your life is still in shambles. How you maintain your sobriety coming out to nothing and no support, rebuild is kind of a miracle, frankly, that anyone is able to. And so being able to rebuild in real time does contribute to sobriety outcomes. Our men tell me all the time that their financial stability is a major factor in their long-term sobriety, because that's one less trigger that could lead to relapse and stressor that they carry. So we really view this as all interconnected and contributing to the sobriety outcomes.
Okay.
Thank you for your time. Thank you so much.
So that concludes 35 in-person applications since council over the last several months. So by achievement, not a lot of councils are letting any applicant present it, and not a lot of councils are letting any applicant present in person. So a lot of learning. So with that, we'll go to the council discussion and final award of funding. Our protocol has been to advance for further discussion. Some council members have requested that we have a vote. I think maybe this time around we stick to advance and further discussion, and then after we finalize it, we can decide if we change our protocol for the next round, but I'll open that up for discussion. So do we want to just advance for further discussion and not have the time to review the applications, or we want to have a formal vote right now? Open that up for quick discussion.
On the ones from today.
Correct. Just a reminder, in the past, we've advanced and further discussion, and then we've had a formal vote. The next meeting, we gave you time to do more research, change opinions, what the council wants to do.
Well, I just have a comment that I think part of the reason that we did that is because it seems a bit unfair to give an up or down on some people who have presented in the same sample of work without hearing all of them. So I still think it's a much more fair process to wait until we've heard all of them and then take a vote. So that we don't, kind of run out of money before we've even heard all of the, applications.
Yeah, I don't disagree because we might get to the end where there's still only this much money and we have to decide what's the most impactful, which we're crossing over.
Yeah, I would. I do what Lynette says.
You forget.
Right, with that, we will.
Last month's presenters.
Well, we're gonna talk about that now. So, the two things we have to do, is first, up or down vote to advance these food for further discussion. And then secondarily, if we have the time, we would have the same conversation. So the last group of 9 presenters that presented in July, none were advanced for further discussion. And there are additional ones in the past that we might want to bring back and look at again to make a final decision. So it is my suggestion that we take a up or down vote to advance further discussion, the ones that we have today. And then go as far as we can on the other 9, and then in the next meeting, we make final voting for all the applications that are still have been presented to this group.
For scope of work for.
But, from at this point, we're talking about additional bunch of scope of works.
Because I think that's the most important part is keeping them together inside of the scope of works, if that makes sense.
Yes, I do.
Yeah.
So I understand what you're saying, yes. So with that, let's take an up or down vote on those that presented today. And this is an informal vote. This is kind of an informal thumbs up. A formal vote will occur at the next meeting after you have further opportunities to get materials. So we can go one by one, or if there's somebody want to advance one for further discussion that they feel comfortable with, we can move quickly on.
Or you just move down the list.
Well, now it's okay. So for the first one is Silver Key, if you go back. Go ahead. Silver Key, just to remind you, Silver Key Senior Services. Is there a decision to advance them for further consideration?
I think for $47,000 and they serve 300 seniors. It's a bargain.
Yeah, I would be in favor of moving them forward.
So can we get a informal thumbs up? We're gonna move them for further discussion.
Yeah.
I'm seeing that as consensus, okay? So with that, we remove Silver Key Senior Services for further discussion and we'll have a formal vote at the next meeting. Next, we have is next chapter.
That's a no-brainer, my opinion.
Say no brainer? That's what strong words from Jake.
That is.
That is. I'll sit in my corner.
I agree. I think it's a really strong program and I respectfully, we have a lot of programs that do not have, and I understand that UC Health is unique in why they're able to do that, but having the strong backbone of being able to track and really show results and outcomes is really strong there. It is a very large amount, but I will also say, especially their work with veterans, and I really appreciate the pointing out that group actually is a third of our population when you look at all of the different families and aspects. And I think if there is any group that deserves our respect and dedication to really make sure that they are served in this capacity, it's veterans. So I'm also a big fan. Thumbs up for me, Jake.
Okay, so, consensus again, okay, so, next up is Antelope Recovery.
Yes.
Yes. I have a question if this would be advanced for further discussion. And a thumbs up if you agree. I see, 2 council, commissioners, council members here who are not, thumbs up, so is your decision not to advance it for discussion, David, for that?
I think we have enough.
We have enough, okay, so we have a consensus to go, but.
Yeah, no, I was just reviewing it still, if having that consensus go, I was still reading, sorry.
Perfect, then we'll make it.
My notes, but I agree with.
Yeah, we'll have a
I
consensus.
think we had a majority.
Yeah, majority, so we'll keep going. Okay, next up, just as a refresher, up there on the screen here, we had Serenity Paws. Any thumbs up on Serenity Paws for further discussion?
For me, I just really have a hard time doing, again, how it's improving or educating or preventing opioid abuse, suicide abuse, mental health or education. I think it's a very, it's a very unique program, and I think it's probably, there's a huge need. I just don't see how it supports what we're doing with the opioid council.
So we have the folks here, maybe they can, if you want to.
Because you didn't have very many questions, but we are, providing them with a skilled trade and education, so that, and then housing and rides and ESA certification and housing. And I was gonna ask, I don't know where she went, that it just opened up 52 beds. Do you guys accept dogs? Do you guys accept dogs?
We do not.
Yeah.
And there are moments that we worked with some organization. But it's pretty rare that individuals seeking help in our program have animals, actually, which is surprising.
Interesting.
But still, obviously, valuable resource.
Yeah. But you've seen with our candidates, one of the biggest holdups for them going into detox, the reason they don't want to get sober is because they don't know where their pet's gonna end up. That's their support system. So to be able to help them get into the actual process of detox and then also help them train up to go back to their community as your candidates and your coaches. An essential role is to help them feel that their pet will be taken care of.
And we even had one candidate that hadn't had a job for 30 years. And the labor that it takes to keep them on a job, he is now paying into the system. He took the family medical leave because he needed surgery. That's one less person off of what you guys were talking about in jail and how much it costs them on the streets or in jail or where they're going, where it's costing lots of money to take care of them.
No, I think it's a very good program and I very support the program, but for $250,000,
Yeah, my concern, I also think it's a good program. I know the rescue mission does deals with a number of folks that have pets and stuff like that. It's become part of the program. But the problem is the bucket's only so big, and I'm pretty confident this would get weeded out once we prioritize the money to all the other things that we've kind of seen. So that's why I kind of am pre-visioning that this is not gonna make the cut.
So any further discussion?
I do, but I think Carrie's first.
Thank you. Yeah, so I just to think, and I think some great comments, that when we're talking about the highest and best use of these dollars, I just don't think that that is the highest and best use, especially compared to some of the very effective programs that we have. I'm also still not sure that it really fits fully into what the intent is from the program perspective.
So, yeah, so I think, I understand that I kind of struggle a little bit too, but I do know there is a value for the people that we work with. Because if they're going into recovery facilities or they're going into detox, they can't leave their dog at the mission. They have nowhere to leave their pet. And so the ability to say your pet will be safe, because I've had people on my own team take pets home while somebody went to detox to take care of them so that they could get them in. So I know the need is there. And it does help people get in when they know that, because they value their pets at a level that most of us couldn't even comprehend, because it is the one thing that you have. So I see the value in it from that perspective. For that subset of individuals on the street with pets, no one to watch them.
So it doesn't seem like we have a consensus to move them forward for the discussion. So with that, we'll move to the next group, it's convergent.
Did we not have a consensus?
We do not have anything.
Did we vote?
We didn't really give thumbs up.
Yeah, so the only vote happens with the actual vote to fund, you kind of form the advancement.
Did we have an informal vote?
He didn't call it up.
So then let's.
I would like to do an informal
I'll
vote.
that. Okay, how about an informal vote for serenity, pause for a thumbs up if you'd like to advance it.
Prior to that, this is for further discussion. Again, this isn't a final, and I appreciate your projecting out, sir, that this may not fit in our purview. But I think there's enough discussion in the room that we should have the further discussion. So my vote is thumbs up to move forward.
So let's take
Yeah.
thumbs
Well,
up.
before we do that, I was kind of thinking the same thing. I wonder if it wouldn't be a good idea, we've done with others, the opportunity to come back and answer questions of people after we've had the opportunity. Obviously, we have limited time to consider these things, but there's been some ideas on both sides of this thing. I think it'd be worthwhile.
yeah, I wanna personally just have a bit more time to analyze.
Okay, so let's take a formal vote if we'd like to move this for further discussion. So thumbs up if you want like to do that. All right, so it moves for further discussion. Okay, thank you for that. Sorry for that. No problem. Let's go to convergent reentry skills. Is anyone seeking to move this for further discussion? Okay, I'm not seeing any council member for further discussion. So with that, conversion do not advance for further discussion. To the next slide. CEC analytics. Is anyone interested in moving this to the next round for further discussion?
Sorry, can I just need a little more time on that?
I'm sorry. Okay.
Were they one that already was established in another location and now they're wanting to open here? I just need a refresher.
Sorry, yeah, so the with all options, frankly,
He left,
conversion still in the room.
he left.
You left.
It wasn't real clear.
When we go for the further discussion time period, do they get the opportunity to come back and present again or answer more questions at that time? What the DA Allen was saying,
We've done that in the past, where we have just directed questions at them.
like in the next session or
Yeah.
right now
There.
in the next session?
Even, we've done it at the time and then also at a subsequent, so.
Okay, I think on this one, I would like to maybe hear more to be able to make a decision. I don't feel like I quite. But I might be the only one, so I will give it on for further discussion, but.
What do others think? So I have one thumbs up for further discussion. Is anyone else interested in further discussion on this topic? So, okay, I noted that there is one, but there's it's not advanced for further discussion. So with that, we have our CEC analytics. Anyone voting to have that for further discussion? This is a wastewater treatment one once again.
So I really appreciate the comments that Commissioner Gardner made about, should we look at them as potentially contracting as opposed to, doing the grant, the more traditional grant process. This information is really valuable to have for our community, and it'd be really helpful in furthering the discussion on how much use is actually happening. I agree, it's probably not in the right bucket if we want to keep it in this.
Could we just ask maybe, Amanda, do you have any recommendations on, rather than moving this one forward, what we might do to continue discussion on potentially contracting on this one?
Yeah, absolutely. So if you're looking to contract this one out, we would do either an RFP or an RFQ, some sort of procurement to procure it as a contract for services rather than a grant.
Like through the county or?
Yeah, the county
Utility? Okay.
Yeah. And so in my own opinion, I think that makes more sense if we're looking for an analytical tool like that, that gives the council more levity to put in, data solutions that they're looking for, as opposed to just giving them a grant, which is, here, we'd like to further the mission of your organization. When you do a contract for services and you're looking at a tool like this, you can build in those outcomes that you're expecting.
We can also talk to CSU.
Yeah, I
And-
know CSU does do some of this already.
Because it's a community benefit. They will do some of these things because it's your, so we can talk to utilities and see
Yeah.
if they're in connection with them and how that looks too, because they might just take care of this as well as a community benefit. They've done that in the past as a community
You
benefit.
mean CSU would?
Yeah,
I think that would be great. The only thing is we may want to, even though it may not be every metro district or whatever, also discuss the other areas. But I would say, can we just put that on the agenda for having a discussion on utilizing those?
Yeah,
I think we have a dashboard that we're supposed to have at some point, and like I could see this as being valuable data to utilize.
Well, can I ask a question on the CSU part of it? If we went that route, would we have access to the full data, or would it be proprietary to CSU and then they would just give us?
no, they would give us access to the whole day if it's a community benefit. They do those things all the time, but it would just be Colorado Springs service area. The other ones, he would have to figure out those, but yes, we could get all that.
And you may not, but the number of different opioids that this group is testing for, does CSU, do they have the ability to test for all, what is it? The gentleman in the back, how many do you test for?
We see anywhere between 8,000 to 18,000 compounds. So for potential alternatives, we see about
Maybe we need
I
to.
think they do their own, but meaning they might find this company is a value because they work with zillions of
Got it.
companies, right?
Okay.
As a community benefit, they might do that for the service area of Colorado Springs alone. These other service areas would be different, but we can definitely look into it. And I don't think they're doing their own anyway. I think it's all outsourced anyway.
If we do it through CSU's utilities, then like with a partial get. That's
Right.
That's what I mean. They would have to do their own.
Okay, that's what I'm saying. Can we just maybe put it on the agenda to have a full discussion of this and maybe we can reach out to Travis or
Well,
whatever
I'm
you
sure
guys
it's
can
right
do your
now.
thing. And then also, so find out what,
Setbacks.
yes, find out whatever you do, like maybe there's like a, an IGA or something.
Sure.
We would wanna do, and then have a discussion about, well, great, if CSU is going to do this. But they're, probably the smaller metro districts and things like that may not necessarily be willing to, is that something that we wanna do to complement? And be just really grateful for what CSU is willing to.
But keeping in mind in the region, if they have something in the region that's higher, it's probably the whole region. It's probably not just Colorado Springs. Like if there's a rise in, like I said, the benzos or the fentanyls or whatever, it's probably not just. See, it's the other regions too, right? I mean.
So
From here to Maggie's Farm, right?
you're starting to say something. Dick.
For your dope.
Yeah, I was just curious actually, as far as that with the different regions, and I absolutely agree, we should just put this on for further discussion. What I would like to know for that next discussion in a month, because it's a contract work, right? El Paso County is holding the funds for Region 16, so how with that contract work could technically Keller County still be able to do that through contract work? Is it Region 16 or is it El Paso County? That kind of differentiation, and I like to have that just kind of ready to go for the next discussion in a month.
Got it. And I could give a basic answer on how this works. So El Paso County is the fiscal agent
Right.
for the opioid council, meaning staff services like, running procurement that I'm going to talk about next on the agenda are run through El Paso County. And then as far as the actual contract itself, that's what we can hammer out into. Exactly.
Right, have all these different municipalities on the contract itself. Okay, that sounds great.
Okay, so as I understand it, we're not advancing this for further discussion, but we are gonna put it on a future agenda item.
I'd like to have done the next agenda, item if we can fit it in.
Okay, so I'll put it on the next agenda item, the next meeting, but not in the same realm as voting on it for a endorsement.
And by then we'll probably have more information for you.
Okay, and the last one is,
Just real quick, are you able to come back to our next meeting?
Sure.
Okay.
Yeah, happy to do so.
comes from Canada for the record, but these buildings. So, next up is Step Springs. So Step Springs is, the last one, thumbs up on Step Springs, it looks like it's unanimous thumbs up on Step Springs. So we have included the applicants for this round that have been advanced. We still need to go back and look at July applicants, but before we do that, the next funding the next topic on the agenda is approval of award of contract for high concentration marijuana. Just like they're possibly talking about doing a contract for services for potential wastewater treatment, did a contract for services for high concentration marijuana proposal. There was a subcommittee developed, the subcommittee was developed and voted on by this council to come back to this council with a recommendation. Becky's in the room, thank you. So at this point, I want to bring Becky up, and I wanted the subcommittee members that include Commissioner Geithner, Councilwoman Yvette Pro Iverson, and Lieutenant Jake Marcus, and one other to have a conversation about their recommendations.
Before we move to that, I have another commitment, so I'm gonna have to leave, but I just want to remind everybody that DA staff is working, and we can wrap up by 5.
Yeah, and for those people who have questions, I'm ready to stand downstairs and take questions from community members who are still interested in their vote. Yeah, I'll do that downstairs, that'll be fun.
And then Commissioner Geithner graciously agreed to serve as chair of my absence for the rest of this meeting.
Great. So I guess as a starting question, without Commissioner Stone here, are we able to take the recommendations?
How many subcommittee members do we have? There's 3 or 4.
That's full, yeah, there's 3 of the 4 here.
Yeah, so I would think the subcommittee would make their recommendations and then the council as a whole make their approval.
Okay. So I turn to the committee members and subcommittee members, see if you have any comments or if you have a recommendation.
Jake?
Well, unfortunately, I can't remember the three names over there, so
Yeah.
if we have those three names, if we could pull those up, and then that'll spur
Yeah.
my memory.
I remember one.
So
If you want, James, so we started when the solicitation closed, we received 10 proposals. We had a evaluation subcommittee meeting where we then shortlisted down to 3. And those shortlisted were, and we invited the shortlisted 3 to presentations. That was Gin Ball LLC, One Chance to Grow Up, and BBG&G.
Thank you. Gen Ball, didn't seem like it was, going to necessarily fit, what we were looking for our location. We kind of narrowed it down to the other 2. One Chance to Grow has come in here to present several times to us. Again, they delivered on the presentation to us. The third one, I'm sorry, what was the name?
BBG&G.
Yeah, BBG&G. Very, very nationally, I guess you'd say accredited. That'd be the right word for it.
Yeah, not local.
Not really local. They're very nationalized. They seems to have kind of a good platform, but it wasn't really geared exactly what we needed to get done.
That's great.
Yes.
Just need clarification that this agenda item impacts people that are always going to be here, correct, to make a decision? Versus we have people in the room that presented last month that are maybe waiting to hear something from us, and we're gonna run out of time.
Yeah, so there are 9 groups that were not advanced for further discussion at the last meeting. I'm going to give an opportunity, but it is belief, because we had a discussion then, that's the only time that no one of the groups were advanced for further discussion. So the thought is.
We just
that-
didn't get to it, correct?
We had discussion and there was debate back and forth, and it didn't seem like there was a consensus, so we can go to that. But this is an agenda item that's kind of been on for a while, so I think that it was supposed to be a pretty quick agenda item because there was a kind of general consensus. So I'll let
I
Lieutenant Marcus
apologize.
finish the points
I
on.
just wanted to
I understand.
recognize there were people in the room that would like to join on that next one.
Carrie, you have anything to add?
Yeah, I think you did a pretty good job of describing it. When listening to the presentation, to me, it was very clear, and I think it was, consensus from the group, that it was pretty clear right away. That there was really only one organization that stood out that had the appropriate knowledge of our community, plus the track record of doing these types of large campaigns. And also is personally invested in the message, whereas, you're hiring a group who would make any message out there, and in this group, One Chance to Grow Up is already focused on this as a mission, so there's already kind of value adds to that. And so I think One Chance to Grow Up was the unanimous recommendation. I know that Commissioner Stone is not here today, but it was, I think, very clear from all of us after seeing the presentation that they truly were the best option and would be what we would recommend.
Yeah, it was his highest score too, so he also concurred with that. So it was unanimous between the 4 of us.
So the subcommittee made a unanimous recommendation to this body to vote to award contract for high concentration marijuana and opioid use disorder, RFP number 25017. At that point, I would like to see if anybody would move to accept that subcommittee's recommendation. It would take a formal vote of this commission to fund it.
So moved.
Any seconds?
Second.
All in favor?
Aye.
Any abstentions? Questions? No. So that has been approved. So One Chance to Grow has been awarded the contract for high concentration marijuana use disorder marketing campaign, RFP number 25017. With that, we'll return to the July applicants and we'll see how many we can get through. If you can take it to slide 50. So the first one was Diversus Health. They presented last month in July. And once again, we have groups that had presented that earlier that also have to come. We have to decide if we want to advance further discussion and have to move on. But Diversus Health was the first one. I'm going to refresh your recollection by showing the screen. And to see if anybody's interested in advancing this Diversus Health for further discussion. Okay, here it is. Reminder, this is the main objectives. We heard them last month.
You want a thumbs up or?
Yeah, kind of a thumbs up if you want to advance to versus help for further discussion. In line with what happened last month, there is not a desire of this group to advance it versus help for further discussion. So with that, we'll move to the next one. Safe side recovery. So I see, I would like to see if there's an informal vote to advance safe side recovery for further discussion. I see one thumbs up. Are there additional? I see two thumbs up. Further discussion, not a formal vote for funding. I see three thumbs up out of the members of the room.
I don't have strong feelings, so. I'll go.
Okay. So we have three thumbs up for further discussion. Is anyone else interested in advancing this for further discussion? Any?
Yeah.
Okay, so we have a 4-3 vote. So that gets advanced for further discussion. Okay. So next up is elevated recovery. I see one thumbs up for further discussion. I see two thumbs up for further discussion.
James, just a clarifying question. Did we not vote or did we not do the thumbs up for exam last month because we ran out of time?
So we had a lot of discussion and a lot of groups were in advance, but we kind of ran out of time to keep going. So I'm not surprised that a lot of these groups aren't being advanced because we had a kind of conversation about it. It's just that we didn't, have an opportunity to close that out because we ran out of time.
Okay.
So we're basically giving them another shot to see if they should be advanced for discussion or not. Not a formal vote for endorsement, but should they get further discussion?
Okay.
Thank you.
Thank you.
So on this one, I see, I don't, anyone thumbs up to advance this further discussion?
I'm not finding this one in my notes, so I apologize.
Oh,
I don't remember.
here's other information if you'd like, to refresh recollection from last month.
So they must be the organization.
So it doesn't look like we have a consensus to advance this for further discussion. I would just say as well, these decisions aren't final. You guys can always come back and say, you know what, we want to advance, we want to further discuss these. Because all the other ones that we have heard through the last few months, we will put on a list, not at the next meeting, but the next meeting, and see if you guys are interested in looking at those again. So this is not final door closed, you're not getting advanced further discussion. Okay? So they were not awarded to be advanced for further discussion. Next up is UPass Regional Health Services District.
For minutes from last meeting, it looks like enemy recovery was thumbs up to be moved for further discussion. That's where I'm getting a little bit. So in the minutes from last meeting, there was a discussion if anyone from July should be advanced without debate, and Commissioner Stone suggested enemy recovery, which is elevated recovery, due to their self-sustaining model. And it appears as though that's what happened, that they were to be moved for discussion.
I think that's maybe why they're not in our notes from last meeting, because.
They were advanced. I'm gonna have to double check my notes on that. Apologies, I'll move pretty quickly.
Well, we already approved those meeting minutes, so I would say that that's what we're doing. You're doing that.
Yeah.
Two.
And that's.
Well, that's, I'm trying to read the minutes as we
Thank
go.
you, thank you, I appreciate that. So UPass Regional.
What does the minute say?
So I'm sorry, for enemy, we'll go with formal vote next meeting, right?
Correct.
Okay.
Can I make a comment on this one, please? So on this one, I know it's really hard to remember these from, so.
That's
tiny.
Wasn't that a dashboard
Tiny.
you presented?
And the app,
Oh, tiny.
yes.
Yes.
So I do think The interesting piece of this one, is the, again, ability, I think we have a huge lack of ability to track, what is actually working towards, making progress overall in our community. And that's what interested me about this one. I know we talked about lowering the amount significantly. So I would be okay with moving this one forward, but knowing that we're going to want to look at that amount.
Cause that was a dashboard, right?
Yeah.
Okay, or even like staging the dollars later based on how we're seeing the first year go. It's all cool. And maybe putting some metrics specifically.
I would also be for just kind of moving this forward as well for further discussion. And having Tiny come back and discuss with us, you know, can we take a smaller bite out of this instead of the full 800,000, maybe 200,000 for an investment to see what kind of return we get back before we really bite off more than we chew.
Okay, so can we get a thumbs up or a thumbs down there? Okay. Give a consensus on a thumbs up to move that forward.
And that for you.
You pass region. The Phoenix. Phoenix. We have a thumbs up on the Phoenix. Community Anchor Academy.
Are we doing? I can make a statement on this one. This one, I was not, for the amount of funding and the amount of individuals and the type of program that it is. While work is very important, I feel like we have a lot of other programs that help people go out and actually find, sustainable jobs in the private sector versus this was much more internal. Just so, again, in comparison, what doesn't mean there are positive benefits to the program, but for highest and best use. And we can't fund everything. I think we have already funded other programs that I feel more confidence in. So I would say I'm not interested in advancing this one at this time.
Historically, where we just.
I think I'm gonna advance to the next one, but I think there'll be another opportunity for your discussion on this to answer the questions. Unless the council wants to give an opportunity to answer right now. I don't think we have time, so.
We have to be out here by
So
5.
we have to be out here.
It's 5.
So, okay, we're gonna come back to that one, but it hasn't been advanced for further discussion at this time. The next one is purposeful change.
Who do you want to kick it off?
So,
I'll happily kick it off and say again, this is one of those ones that I think I would not be comfortable moving forward. Just because again, we have a lot of different programs that are similar, but not the strongest application of policy. Agreed. Any disagreement or do we want to?
well, we kind of, yeah, so I need
Please
some,
do, when they come up, if you guys wouldn't mind just throwing a thumb whichever way to give us a sense. Trying to pick up whether you guys are ready to go or.
so purpose for change was not advanced for further discussion. And again, we had lots of conversation on this group last month. Lydia Hill Institute for Human Resilience, there was some back and forth on this one. So we have 2 thumbs up for further discussion. We have 4 thumbs down for further discussion. Make it 5.
4 has it.
Yeah, so is not advanced for further discussion. And I believe the last one is the fountain police department.
Were we waiting on Jake to give us a review?
Intake program. I would say for the sake of Fountain Police Department, and for the benefit of other law enforcement professionals that couldn't be here today, I would like to have this one moved for further discussion. I think we may have different opinions of it, but I'd like the other more law enforcement professionals in the room to help us answer those questions and kind of move through that. Because there's only 3 of us today, right?
Obviously, I won't be having a thumb here.
Thank you for the reminder. So let's take thumbs on this one.
Thumbs up on that. This has been advanced for further discussion. And with that, that concludes last month, sorry, that concludes last month.
I just want to make sure that, They said we already did approve it, because now I'm realizing it was just initials in the title here versus the full name up there, so I did want to move that one on.
Okay.
If it wasn't, yeah, so I want to make sure that, thank you.
It's a lot. All right, well, thank you for your time today. I don't think we need a motion for adjournment. Thank you.
Probably did make it out.